and I'm going to talk to you about the state of the art on transition from fine needle aspirations to fine needle biopsies. So the objective of this lecture are threefold. One, I'm going to talk about optimizing the needle selection. When do you use FNA and when you use FNB needles, optimizing the sampling maneuvers for getting good tissues, and finally optimizing specimen processing. So this is the last study that we had published on fine needle aspiration of pancreatic masses. So this was a randomized trial of 352 patients with suspected pancreatic mass lesions. Patients were stratified to four groups.
I'm sorry, we can't see it your slides. Can you share?
Yeah, I'm technologically challenged. Do you see the slide, Yogesh, now or not really? Let me see if I need to minimize and come back.
Just share the share icon.
Yeah, and then desktop. Share. System preferences.
I can see Samir and Khalid also. Welcome.
Do you see the slide, Yogesh, or not really?
Not yet.
Okay.
Can you go down at least? There is a green icon, share screen. Can you click on that and then double click your slides? It will show your desktop and then you can.
Okay, yeah, I see the share screen. And then it takes me out. I can press this share. Allow Zoom to share the screen. Okay, open system preferences.
Sham, you need to keep it in the desktop, the PowerPoint presentation, and then you
and then I open. Okay.
You need to keep it in the desktop first.
Okay, let me see. Do you see it now? Or not really?
No, not yet.
Okay. So this is one, I'm now in India. So usually when you're in your office, you've got some good secretaries who are good at doing these things. And unfortunately, I'm very technologically poor with, with technology.
Sham, you open the presentation on the desktop as Khalid said, and then you go to the share screen. When you click the share screen, you will see a lot of windows and you select the window where your presentation is there. You double click on it and your presentation will open. Jason, are you there?
Yes.
Can you help Sham, Jason? Can you guide him?
Dr. Sham, can you see the button share screen in the bottom of your window?
Yeah, I do.
So you click on the share screen button.
Yes.
Then there will be a box coming up. So you find the square where the PowerPoint is. Can you see your PowerPoint in the pop-up screen?
I don't see my PowerPoint on the pop-up screen. It just says desktop one with a big question mark on it. And I don't see anything else.
First of all, did you open your PowerPoint?
Okay, my PowerPoint is...
Did you open your slide?
Yeah, my slides are already open.
Okay, then now you press share screen. Then do you see top left, there is word post screen when in the pop-up window?
In the pop-up window, I do not see any of my slides at all, unfortunately.
Can you see the word screen next to the whiteboard? Can you see the screen?
At the bottom, there is a share screen, Sham.
Yeah,
you see it green?
No.
Yeah, you double click the screen. You double click it.
Okay. And then it says open system preferences. And I'm here again with you guys back. I don't know if my system is later.
You have the green share screen down.
I see it, Khalid. I follow what you say, but it's not getting me into my for some reason into my PowerPoint presentation. I keep doing the same thing over and over.
Yeah,
Yeah,
we
no,
can
no,
see your
Yeah, we
screen
can
now.
see it.
Now.
Yes, yes.
Now
Yeah,
it's okay.
yeah, I could have probably taught
Wow.
each of you EU was better than doing a presentation. All right, so let me now. Okay, is it okay now?
Okay,
Yeah,
perfect.
excellent.
All right. So these are my objectives today about needle selection, optimizing sampling maneuvers, and optimizing the technique of specimen processing. So this is a randomized trial where we performed on EUS-graded FNA of pancreatic masses. 352 patients were randomized to 4 groups, 22 gauge and 25 gauge needles with or without suction. And in this study, you will see that there is not actually much of a difference between the technologies, except that the diagnostic accuracy when you're having rows is fantastic. It's about 95% or higher for most groups, except when you use 22 with suction, because there's a lot of bleeding. However, the other feature, which is the cell block, is dismally low. It's all less than 85%, particularly with a 22 gauge needle with suction. It's only like 79%. And then when you use a 25 gauge with no suction, once again, it's in the ranges of 79. So according to the American College of Gastroenterology, anything that is less than 85% is considered suboptimal. So this study tells us that if you have a pathologist in the room, you've got a fantastic outcome. You've got a diagnosis more than 95% of the time. If you don't have a pathologist in the room, we have a major problem. The cell block yield is significantly low, and it is all less than 80 to 85% for most groups. Therefore, this is a summary slide. The problems with the FNA is, yeah, if you have rows, it's outstanding. If you don't have rows, we have a problem. The cell block is important, unfortunately, for conducting ancillary studies, except like molecular profiling for pancreatic cancer. But if you have a diagnostic yield of 75%, then those testing cannot be performed. Also, when you perform a FNA, you get a cytological aspirate. With a biopsy, you get a lot of tissue, which you can perform molecular profiling. So that's why biopsy is important. Whereas with cytology, we can't do a lot of molecular profiling. And most importantly, not all pathologists can interpret cytopathology. They are all excellent in interpreting a biopsy. Cytology, they're generally not. So consequently, 4 histology needles have been developed. The ProCore, the SharpCore, the Acquire needle, and then the Easy Shot 3 Plus that has recently was in FDA approved. I think somebody is having an echoing on the other side. So this is going to be the difference between a FNA needle and a FNB needle. So I'm going to draw you a simple video that shows the differences. So this is a patient who presents with a pancreatic mass lesion in whom both the procedures were being performed. So we will start first with the FNA. So this is a patient with a pancreatic tail mass that you can see there. And then we are now performing a fine needle aspiration of this mass using the 22 gauge expect needle. This patient also has got metastasis to the liver. So this is a neuroendocrine tumor of the pancreas. So when you perform an FNA with a 22 gauge needle, there you're passing the needle into the biopsy channel. And then you're sampling this using the fanning technique by moving the needle into different quadrants of the mass. And there's you find the cytological aspirate. Then you smear it onto the slide. And then once you smear it on, you perform a few passes for cell block, which is usually the standard of technique. And you can find a nice aspirate without any core tissue. The remaining specimen is now expressed into a cell block. And then we perform next a fine needle biopsy. So here again, the technique is exactly the same, except that the type of needle you use is slightly different. So here we are using the 22 gauge biopsy needle. But you can see the difference in quality of the tissue. It is not an aspirate, but it is more like an histological tissue that is now passed onto the slide. And usually with this, you do not perform a smearing. All that you do is to move the slide across, the tissue across, and this is called a touch imprint cytology. And you can see that there's a thick material, and then it is processed in the same manner. We usually perform 2 passes, in this case for cyclite, but generally a formalin is a much better medium. So here you can see FNA on the left, FNB on the right. FNB is much more cellular for on-site evaluation compared to the FNA specimen, which also is diagnostic, but obviously the FNB is much more cellular. Next, we will move on to have a look at the cell block. This is diagnostic of cancer. All the blue cells are cancer, whereas here you find sparse cellularity, and that is the problems with the FNA needle. So given these, and this was found to be a neuroendocrine tumor of the pancreas. So how do you evaluate a F&B sample? Is it true histology? And is histological tissue clinically relevant? So this is a randomized trial of about 46 patients who were randomized to both FNA and F&B needle. And here you can see the tissue volume is 30 times higher for F&B. The tumor area is again 70 times higher. Fibrosis with F&B needle is positive at least 4 times more than with the FNA needle. And all of them is clinically relevant. If you want to look at the clinical implications, when you use a F&B needle, Rose is positive 100% of the time. You get a diagnosis usually within 1 or 2 passes if you are a good endosonographer, and the cell block yield is significantly higher with F&B at about 98% compared to only 82% with the FNA needle. And this is very important. Now let's look at these findings outside of the randomized trial setting. So this is our study of 3,020 patients. So up to the year 2015, we used a FNA needle, and then we used a F&B needle subsequently. You can see the number of passes for Rose significantly decreased from 2.5 to almost 1 pass when we moved from FNA to F&B. And when you look at cell block yield as well, it used to be about 65 to 70%. And then gradually when we transition to F&B, now the yield is greater than 90% on almost all circumstances. And this is again a summary slide of this study. So the diagnostic yield for Rose is not significantly different between both needles, because if you have a pathologist in the room, it really doesn't matter. You're going to stop the procedure when you have a diagnosis. On the other hand, the number of passes is all significantly less with the F&B needle. Usually with a single pass, you get more tissue, whether it is for pancreatic or bile duct mass, lymph node, subepithelial mass, or any other lesion. And this is probably the most telling of all slides. Here's your diagnostic adequacy on cell block. And you can see that the F&B needle scores over the FNA needle in pretty much every single circumstance, whether it is a pancreatic lesion or any other lesion. Most importantly, those days when we did FNA, if you don't have an answer in the room, we would not even bother to check the cell block because we never had a diagnosis. But now, when your FNA in the room is not diagnostic, the F&B happens to be diagnostic about 70% of the time when you have a negative Rose. And this again is statistically significant. That's why we think, at least for sampling of solid masses, FNA, the time of FNA has come to an end. It's all about final biopsies, and this is critical moving forward. Is FNA dead? Probably not. I really think when you aspirate a cyst with a 22 gauge F&B needle, you can have bleeding. So for aspiration of cysts, we always use only a FNA needle. If somebody is on a coagulopathy and you can't stop their aspirin and Plavix because of cardiac risk factors, we think you can use the 22 or 25 gauge FNA needle because the risk of bleeding is low. And in some patients, even if you stop aspirin, Plavix, they remain borderline coagulopathic. And once again, to minimize bleeding, a 25 gauge FNA needle may be a consideration in these patients. Now we have talked about F&B needles. There are now 4 different F&B needles in the market: the Acquire, the sharp core needle, and then which is called the fork tip needle, the Acquire or the Francis needle, and then the Manganese Tip or the easy shot needle from Olympus. So if this is a very important question. So when you've got all 4 needles, the question is, what do you want from them? Our desires are almost the same. You want a highly cellular sample for ancillary and molecular studies. You want a diagnostic accuracy and adequacy of greater than 90%. You don't want to use a pathologist in the room if possible. And then you want to just use formalin for collection because it is universally available, contrary to other mediums that are all dependent on the geography. And more importantly, is that one needle that you can use. You perform a single pass, you will have a diagnosis in more than 90% of the procedures, so that you open the needle, you perform one pass, you put it in formalin, and you're done. So this randomized trial was conducted to answer this question. For a given, in addition to that, for a given F&B needle, we have multiple techniques. You use suction, some people use no suction, some people use stylet retraction. There's something called the wet suction technique, which is not very popular. So we thought, in addition to choosing the needle, let's randomize the patients to these 3 techniques so that we can marry the needle with a particular technique. Maybe the Francine needle might be good with no suction. Maybe the fork tip will be good with stylet retraction and so on. So this was a double arm randomized trial with a primary objective being degree of cellularity, which is proportion of histological core tissue in a tissue sample on one single pass. The secondary objectives were to evaluate the diagnostic adequacy and accuracy on a single pass, and to identify the most sampling technique for every F&B needle. And all specimens were processed like a surgical sample in formalin. So in this study, we randomized patients to the 4 different needles. And what we found is this. When you use the Francine needle, you got a diagnostic adequacy of 100% with a cellularity of 66%, which means in the whole slide, 66% of the slide is composed of core tissue. And the median was about 73%, which is very, very high for the stylet retraction technique for the Francine needle, which is called acquire. For the fork tip needle, which is called the sharp core needle, what you will find is the diagnostic adequacy is also between 95 to 100% for both not using suction and for stylet retraction. Also, the cellularity is significantly higher, anywhere between 55 to 95 percentage points. So on a single pass, we could get a diagnostic adequacy of more than 90% with very high cellularity using the stylet retraction technique for Francine, and then the stylet retraction and no suction technique for the fork tip needle. Now for the reverse bubble needle, which is called Procore, what we found is that none of the techniques were very good. This is needle function actually like an FNA needle, and when you used suction, we could get a diagnostic adequacy of 85%. So this is significantly inferior compared to the prior needles. And also, unfortunately, look at the cellularity. Only 23% of the specimen contains core tissue. So this was a disappointment because we didn't get good histological tissue. But even for an adequacy of 85%, you have to use suction. Now, let us look at the Manganese Tip Needle from Olympus. Here again, we got a diagnostic adequacy, which was 100%, but this again happened only with suction. So for the Procore needle and for the Manganese Tip Needle or the EC Short 3 needle, you have to use suction like an FNA needle to get any tissue, but mostly the cellularity is only 23%, which is significantly less compared to the 60 to 90% with the Francine and fork tip needle. Also, another take-home message, when you use the Procore or the Manganese Tip Needle, you have to perform 3 passes. So if you perform only 1 pass, you're not going to get a diagnosis. So you must perform at least 3 passes to achieve high cellularity and diagnostic adequacy of greater than 90%. So this is our summary slide. So for the Francine and fork tip needle, stylet retraction appears to be the best technique. And for the reverse bubble and Manganese Tip Needle, nothing works good. But I think if you want a diagnostic adequacy and accuracy of 90%, you have to use suction and preferably perform at least 3 passes. So now let's look at operating characteristics. Which FNB needle is the best outcome on a single pass? Once again, thumbs down. The Francine and the fork tip needle will give you a diagnostic sensitivity of more than 90, up to almost 97%, which is significantly inferior for other types of needles that are commercially available. So this is again a digital imaging. So when you use the Francine needle, you can see high cellularity. This is the cell block, which is again very profusely cellular. And here is the digital profiling using the Nikon software. And with the fork tip needle, once again you achieve good cellularity. On the other hand, when you use the later needles, which is the Procore and the Manganese Tip Needle, you find only sparse cellularity. And once again here on cell block, it's hardly cellular at all with Procore, and you can find the blue is primarily blood and the red is just minimal core tissue, whereas with the Francine and fork tip you get so much core tissue, but it is much less with the Manganese Tip Needle and the reverse bubble needle. So this once again is a diagnostic is a diagrammatic illustration that tells you that the fork tip and the Francine needle gives you much better cellularity and a much superior diagnostic accuracy. But in FNA and FNB, don't forget the basics. Fanning the needle is important. There's no point going back in the same place over and over. Your specimen is going to be bloody. So with these needles, always perform the fanning technique. And here is a simple example of a 68-year-old patient referred for a pancreatic uncinate mass. And there is a lesion that is about 2.5 centimeters. And here we are using the fork tip needle, also called the sharp core needle, manufactured by Medtronic. And here you can see us wanting to move the needle into 4 different quadrants. And usually we prefer to pass the needle 4 different times in each quadrant. And then using the up-down dial with minimal elevator movement, you move the needle in different quadrants of the mass to get good tissue. And once you do that, invariably you'll get some good quality material that you are now using touch imprint cytology. And then you put the remaining in formalin, just a single pass in formalin. And then after you do that, you can see that the rose is very cellular, and then your cell block also will be very rich. And this again is a randomized trial comparing the fanning and the standard technique. And you can see that when you use the fanning technique on the very first pass, you will have a diagnosis 86% of the time compared to only 58% with conventional techniques. Once more, basics, FNB sample, always use formalin. If you use FNA, formalin may not be the best option. You have to use cytolite, and please perform multiple passes so that you can perform your core sample on it. When you suspect a lymphoma, and if you're sampling a lymph node, always use your RPMI medium. Do not use a formalin because it will lyse the tissue and there will not be enough material. And also cytolite may not be very good. If you put the specimen in cytolite, and if you're suspecting a lymphoma, it has to be transferred to another medium within a 4-hour duration. So for the best practices in 2020, my recommendation is use a 22 gauge FNB needle. Always fan the needle. The stylet retraction technique is most optimal for the fork tip on the Francine needle. Make sure you collect your specimens in formalin. And then if you do all of this, then you can be assured of more than a 90% adequacy and accuracy on a single pass using one of the 2 needles in all your patients. So to conclude, the FNB needles are most optimal for tissue acquisition as they yield highly cellular, diagnostically adequate and accurate samples on a single pass in greater than 90% of the procedures, and you will not require a pathologist for most cases. Your cell block will yield the desired outcomes in most patients. Thank you.
Shyam, as always, a very excellent and a lucid talk. Regarding the slow pull technique, what's your take on it? I don't think you...
we always used to be very skeptical about the technique. That's why we thought we should prove it on a randomized trial. So it does appear that when you retract the stylet very slowly and you move the needle in different quadrants, it looks like tissue acquisition is much better with this technique than compared to suction. If you use suction, the persistence of suction at all times makes your specimen bloody. When you use no suction, it's okay with the Francine and the fork tip needle. But for the other 2 needles, the Manganese tip and the reverse bubble needle, your outcomes are going to be extremely poor. So when you use the stylet retraction, it causes a continuous negative pressure, and it appears to be the needle of choice for both the Francine and the fork tip. If you ask me, what is the physiology and the physics behind it, we really don't know, but we really feel that you retract the stylet, you don't have to do it all the way, you just perform your 4x4 pass through different quadrants, and by then the stylet will be halfway through the needle, and then you can discontinue the procedure, and eventually you should have enough tissue. When you with histological needles, you don't have to worry about specimen bloodiness. Specimen bloodiness does not bother pathologists when you process the specimen as a FNB sample. Only for FNA, when you have a lot of blood, the pathologist does have a problem.
I think Khalid has a question. Khalid?
Yes, Sham, excellent presentation. Sham, if like your case, pancreatic mass with the liver mets, would you biopsy the pancreatic mass or the mets?
So I think if there's a patient with no other cancer, on a CT scan you find your pancreatic mass with liver met, I think it's very reasonable to just go to the liver met and get adequate tissue, and then if it is positive, you can stop, you know the answer. But if you've got a patient with, say, for example, a woman who's got a history of breast cancer, and has got a small pancreatic mass with a liver met, then I think it is imperative to sample both to make sure that the met is also from the primary mass, and then the adenocarcinoma on the pancreatic biopsy, for example, is not as a consequence of some sort of a metastasis from the liver, from the breast, and the pancreas is just an innocent bystander. So to make it very short, if there's only one primary with a metastasis to the liver, always go to the liver. If it is positive, and if you really want it, you can go to the primary. But in a patient with a history of prior malignancy, it's important to sample both.
And Sham, what about the 19 gauge needle? Is it really obsolete, or?
So we used to use the 19 gauge FNA needle, which we called the Flex 19 from Boston Scientific. We used to use it, but we used to use it because we did not have biopsy needles. So we thought when you use a big caliber needle, you'll get core tissue. But now I think with the 22 gauge needle, FNB, it gives you much better quality tissue. The second problem with the 19 gauge needle is when you perform transgastric FNA, it's not a problem. But once you go beyond the pylorus, it's very difficult to get the needle out, and then the movements become clumsy. You can't perform fanning, it increases bloodiness and so on. So nobody is using the regular 19 gauge needle for biopsies. But if you don't have a 22 gauge FNB needle, and FNA is all that you have, and your pathologist is asking you to get your core tissue, then I think it is reasonable to use a 19 gauge FNA. If not, I will not use it.
Another thing about cytolite. So what I understand, so when you use a FNB needle, you just send your sample in formalin, no more in cytolite, is it?
That's correct. I think the formalin is a much better preservative, because if you put it in formalin, it is processed like a hematoxylin eosin, which is a HNE, which is what we do for esophageal and colonic biopsies. We put them in formalin and send it. That is the needle of choice for histopathology. But when you're using it for FNA needles and you're processing it like aspirate, that is when cytolite comes to role. There's nothing wrong in putting your 22 gauge, your FNB samples into cytolite, but our pathologists don't prefer it, because if you put it on cytolite, they still have to create a cell block by spinning it and so on. But if you put it on FNB, you don't have to do that. You can just go straight for preservation and sectioning.
And do you feel that FNA needles are just dying, or like, what is the indication left out for them?
Pancreatic, as I told you, pancreatic cyst aspiration, FNA needle is good. If somebody's on aspirin and Plavix and you can't stop anything, the 25 gauge FNA needle does have a role. If you're very worried about intervening vasculature, particularly sampling liver and so on, I think FNA is okay. But otherwise, I don't think for solid mass lesions, FNA has any role anymore. I think it's pretty dead.
Okay. If no more questions, then thanks, Shyam. Thanks again for a nice talk, and thank you. You could join in from all the way from US to India, and finally we could catch you. Thank you for being a part, and have a safe journey. Thank you,
guys. Thank you. Enjoy your conference. Thank you. Bye-bye.
Thank you. So for the next session, I would invite Dr. Samir to chair the session. So Samir doesn't need any introduction in this part of the world. Samir is the head of the gastroenterology at Rashid Hospital. He's a consultant gastroenterologist, and he is the chair of EGHS, and he is the backbone of gastroenterology in UAE. Samir, please take over.
Thank you. Can you hear me? Thank you, Yogesh, for this invitation and for organizing this nice conference. We enjoyed Shyam's lecture, and now we are having Dr. Reddy from India as well, who really doesn't need any introduction. I mean, he's very famous, very well known. He's the chairman of Asian Institute of Gastroenterology in Hyderabad. He's past president of World Endoscopy Organization. It's really an honor to have him in any of these conferences, and we really miss him. We haven't seen him for the past year, I think now. So he'll be talking about the future of endoscopy within the coming 20 years. Now, with this pandemic, we don't know the future of the pandemic, but at least we will know the future of endoscopy within this coming 20 years. So I don't know whether Dr. Reddy is with us or...
Yeah, I'm here.
He's there.
Hi, Dr. Reddy. How are you?
Hi.
So always nice to see you.
Thank you, Samir. Again, like to thank the Asian US group for this kind honor, and also Yogesh Shastri for this kind invitation. It's always difficult to talk after Shyam because he's so eloquent and he consensus things so very well. But anyway, I'll try and do justice to this topic on future of endoscopy over the next 20 years. I don't know why time limit of 20 years was set, but as I go through, you'll see that some of the so-called futures are already coming into being. So whenever you try and look at what is in the future, the best way is to gaze at the crystal ball. So what I did was I put on my endoscopy hat and looked at the crystal ball to see what is going to be the future of endoscopy. So what I'll do is to try and break it down into three areas: the scope design, diagnostic endoscopy, and therapeutic endoscopy. If you actually look at the conventional endoscope that we're using, the design is actually more than 50 years old. Many years back, this endoscope was made initially in Japan, Germany, and the whole same model continued. if you ask bioengineers about this technology or the way this endoscope is designed, they'll say it's terrible. This is not how we should operate it. But in spite of this, no changes occurred here. But I believe that we now realize that endoscopes will change. They'll, of course, the pattern of endoscopes, already the change is coming in. And one of the reasons these changes are occurring because of the potential of these endoscopes to transmit infection. The CRE infections in duodenoscopes became big news a couple of years back in US, and I think not only was it in literature but also in lay public that this came about. And the reason for this was the complex tip in these side beam scopes, which are difficult to clean. So this actually gave way to potentials of single-use disposable endoscopes coming in. Some of these are already available in Germany, especially the one you see here, the window one was for upper GI and colonoscope. The optics are quite good. It's a digital scope, and you can see the way it's operated is totally different from conventional scope. It's more got like a keypad on which you're operating the scopes, and the visibility is quite clear. So based on this, and because the infection problems are much higher with the duodenoscope, some of the manufacturers started focusing on the duodenoscope to see if they can produce what's called disposable duodenoscope. Again, this is at least one company, Exalt from Boston Scientific, has come out with this duodenoscope costing around $2,500 to $3,000. Each time its use has to be thrown off. Another company which is on the way but not yet still commercially available is coming from a combination of Ambu along with Wilson Cook. So this scope market is heating up, and this is also partly because FDA said that if you can work on a disposable duodenoscope, it's worthwhile. So this was the first world live demonstration by Sham organized in Orlando, and I was actually lucky to be a part of it, and this is probably the first live demonstration of a disposable scope. The reason why I'm showing you this is you can see how easy it is to use the scope. This was a complicated case with infiltration. We did a stenting, and you see what the scope is. Dr. Muthuswamy here is just throwing off the scope. So we pick up the scope from there, and then once you use it, the optics are good. You can do complex procedures. This was a stenting that we're doing in this patient who had a biliary and pancreatic stricture. And after the scope has been used, Dr. Muthuswamy is throwing it off. So this is something that is becoming possible. And in future, are we going to use this more and more? The main problem is the cost. The cost of the scope currently is about $3,000. And again, Sham's groups have estimated that unless it comes to about $600, widespread use won't be there. So there are limited indications, however, especially patients who are, for example, now in this Corona era, if you have a COVID patient requiring an ERCP, you'd probably prefer a disposable scope. Or patients in ICU with multi-organ resistant organisms, again, would require this. The use would increase if the price comes down. If the price is, say, $600, then probably everybody will want to use this rather than the standard duodenoscope, because processing this would be as costly. But still, I think right now, reusable scopes are the ones that are going to be the standard of care. They're getting modified now. We're getting tips which can be cleaned better. All these modifications are to decrease infections. And recently, a seal has been made. Pankaj and his group have reported a seal which can be put on top of this endoscope to completely seal it off from infection. So these modifications may compete with the disposable endoscope, probably because of the price. But still, this is an interesting thought of what is going to happen in future. Robotic endoscopy has become a standard of care in many surgical laparoscopic related surgeries. For example, in urology, prostatectomy is mostly done by robotic surgery. Gynecological surgery is being done. Many oncosurgeries are being done. However, using a flexible fiber optic endoscope, flexible endoscopy, making it robotic had some technical challenges. A few years back, a Singapore group, Lawrence and his group actually made this so-called master-slave robotic endoscope, and you can see these jaws are put in through a standard endoscope. You can actually manipulate these jaws. And you can see the endoscope is just actually a slave. I'm just putting the scope in. The master is behind manipulating this, doing a very large ESD. With my expertise in ESD, I would take at least 8 hours to do this, but using the robotic scope, we could actually do it in just 17 minutes. So you see, you can take it off completely and follow up all these cases. We published a case series sometime back. Since then, robotic endoscopy has not picked up as we expected, mainly because of, again, the costs involved. The potential of this type of manipulation was limited to only, for example, ESDs, and unless it's more universally used, it was not something that could be coming up very fast. But now, recently, there's been a company which is commercially selling these scopes, mainly for rectal ESDs, and hopefully, as these scopes become thinner, more malleable, they'll be much more widely used. But this probably is going to be future. At least 20 years from now, I can definitely see these robotic endoscopies playing a large part in our endoscopy practice. Along with this, there's certain other modifications. This is from the Hong Kong group, Philip Chu and others, who showed that using a 3D endoscope, they actually have a lot of experience with 3D laparoscopes now, laparoscopic surgeons. Using the same thing, using a 3D endoscope, they showed that you can actually do a better ESD or third space endoscopy, and because you get a better depth. Again, this is not available commercially. It may take at least 10 years to be something that can be commonly used, but some of the endoscopy companies are actually working on this. So we next come to diagnostic endoscopy. In diagnostic endoscopy, image-enhanced endoscopy has become the standard of care. I don't think any unit worthwhile in the world who don't do image-enhanced endoscopy. We have actually decreased our white light endoscopy. We are doing more narrowband imaging, or if you have Fugiscopes, it's LCA or BLI or Pentexcopes, iScan. So a variety of imaging is coming into. What this enhanced imaging does is it not only picks up very early lesions which can be missed by white light, but also gives us an indication whether these lesions can be removed endoscopically or not based upon the infiltration into submucosal or deeper tissue. So I think this is a big boon to us, and this is going to become more and more common in future. But we're going to get much more sophisticated. Not only are we going to use this enhanced image endoscope, and some of this again is available, endocytoscopy, where you can see to a depth of 50 microns, confocal fluorescence microscopy, deeper 250 microns, and of course autofluorescence, which guesses a lesion, which is actually more like a screening method to tell us whether there is a malignant lesion or not, and of course OCT. All these are going to come in now, and I think these are going to be added to a standard endoscope. Again, this may not immediately, may not be tomorrow, but certainly they are going to come fast. This is the EndoBrain, the new endocytoscope, and this is Professor Kudo, who's actually been responsible for developing this, and you can see that this EndoBrain uses endocytoscopy and then tells us whether you're dealing with a neoplastic lesion, what is the certainty of that. 85% it says. So which means that the chance of this being an adenoma is very high, not hyperplastic lesion, and therefore will require resection. We have started recently doing a study with EndoBrain, which is actually an artificial intelligence added to an endocytoscope, and it's quite remarkable of how you can use this. And of course, at present, it seems more like a fun toy to use, but I think more and more as we start using it, it's going to become an important tool in future, so that even a novice endoscopist can be as expert as Professor Kudo in telling you whether you're dealing with a JNET type 1 or type 2 or type 2B lesion, so that you know you can then try and resect these lesions based on that. But the real future, I think, is going to be molecular bioendoscopy, where tumor-targeted fluorescence cocktails are given, and these go inside the body and specifically attach to the tumor cells. And when they're specifically attached to tumor cells, you can get fluorescence from this, and this fluorescence can be picked up by a confocal endoscope. Very, very early lesions. In this case, this was a lesion which probably was not even seen by white light or even the enhanced image endoscopy was picked up. In fact, it's believed that using this bioendoscopy, we may be better than even the pathologists in telling that, okay, this is potential malignant lesion here, which could be missed even by histopathology. So I think this is something very exciting. Again, I believe this is not very far off. There's been a lot of animal work on this area, working on gastric cancer, colonic cancer, and I think this is something we should look forward to. Of course, the single operator digital cholangioscopy is already available. So what in the future, what this is going to be used is trying to use this when without radiation, direct visualization for tissue access and directed therapies. And already the article, this is from Subhash and his group from Stanford, who have actually published a study showing that you don't require fluoroscopy at all. Using a single operator digital cholangioscope, you can remove CBD stones and so on without fluoroscopy. And we actually are doing a trial in this, but we'll have to wait and watch. So this in future may become more and more common, that you cut down on your fluoroscopy. And you can see why this is so useful. These are two pictures of actually strictures in the common hepatic common bile duct. All other investigations were negative. This patient is supposed to go for surgery, cholangiocarcinoma. But when we did cholangioscopy, you can see on the right side, there was a tumor here from which biopsies were taken. On the left side, you will see a lot of caseous material coming out. This caseous material, of course, was AFP positive. The tumor was a lymphoma, which dramatically melted with a combination of radiotherapy and chemotherapy. So you can see that we have avoided major surgery in these patients, and this type of imaging is going to be more and more popular. In fact, the third generation of spicolangoscope is going to come in very soon, which is better views and so on. Actually, it's 3+ generation. And we're going to get much more technology so that you can do all sorts of things in the bile duct or pancreatic duct, like ablations, resections, and so on. So now coming to the last aspect of this is therapeutic endoscopy is going to dramatically change also. This is an example of a gel which is currently just been coming out from Korea, where you have patients who have a bleed, and what this gel does is not only stop the bleed, but stays on top of this ulcer for about 72 hours and then drops off, by which time the risk of future bleeds will be very less. In fact, this is potentially being used in patients who have large ESDs. You know that delayed bleed can occur after 72 hours, and all you have to do is do the ESD, spray this gel and sleep. You know that this patient is going to be safe because the gel has a protection which lasts for a very long time, unlike the standard hemospray, which is going off in a few hours time. So many of these future gels are going to come. I believe that these gels can be used not only for bleeding, to prevent bleeding, but also to dissect tissues. And this is something that's going to happen. You inject the gel submucosally, and it's going to do a spontaneous auto dissection of the tissues. Similarly, to close perforations, probably we'll be using gels like this. So gel engineering is getting into, I think this is a big area. And for example, there is now studies where this gel engineering is used to coat the duodenum second, third, and fourth part to prevent absorption and also decrease diabetes mellitus. The other area where there's been fairly dramatic changes, metal stents are being used more and more, replacing the older plastic stent technology. In fact, both for terminal malignancy, where only plastic was used, we now have data from this Amsterdam study showing that in these cases, metal stents are as good or economically better than using plastic stents. And also in benign strictures, this was a study we published in patients with chronic pancreatitis, transplant, or post-cholecystectomy. We have shown that this is useful. And now a randomized controlled trial has come comparing plastic versus metal stents in benign strictures, showing that completely covered plastic stents may be better in these cases in view of the less procedures. So I think what is going to happen is the so-called plastic stents that we're using in ERCP is going to go into the graveyard of our endoscopy museums, and there's going to be the new dawn of so-called metal stents. They're getting very specialized for each. For example, pancreatic fluid, we use specialized stents. We have different stents for left or right hepatic duct and so on. I think it's going to be a huge new technologies that are coming in this area. And now again, coming finally to an area which I think is going to overtake all other areas of endoscopy, the endoscopic ultrasound. In fact, this forum is, I think, basically experts of US are meeting. I was very skeptical about how US would take off. In fact, I'd argue with Shyam many times about its use, but I keep realizing now as progress is occurring that US is really going to replace many areas of ERCP related work. US biliary drainage can become in future one of the main methods, and in bypassing ERCP could become the primary method of how we drain the bile ducts. I think this was a study by Shyam's group McCain, which actually looked at primary biliary decompression for pancreatic cancer without ERCP, showing less amount of pancreatitis. Some of these things may become very common in future. I think with the younger generation becoming very good at EUS and ERCP skills coming down, I think this may replace ERCP for biliary drainage. Similarly, US, I think, is taking over in areas like this. For example, for gallbladder therapies, we now have techniques to make a hole puncture, put a lumen opposing stent and go in. And sometimes you can actually, this is an example from Anthony Thio's unit from Hong Kong, where they actually went inside the stent and did ESDs, diagnosed early dysplastic lesions and so on. So we can see a future where sometimes you can do a chemical cholecystectomy using these techniques, maybe avoiding standard cholecystectomies. This could again be the future. But I think the immediate future, and which has already come now, I used to think this is a long future, but now is US guided gastrojejunostomy using these lamps. There are several techniques or methods to do this. Whatever technique you do, it's so easy to do this that I think it's slowly going to replace standard laparoscopic gastrojejunostomies. Is going to replace enteral stents, because I think this is superior to all this. And there are already studies, comparative studies showing that this indeed is better. And I think this is not only going to be 20 years, the next immediate future, I think endoscopic ultrasound gastrojejunostomy is going to take over other methods. Of course, bariatric surgery is a big new target for endoscopists. And I think, again, this is a future I see very quickly coming up. We are now doing a variety of endoscopic sleeve gastroplasty and other techniques. These are being modified. They are probably more physiological than doing laparoscopic sleeve gastrectomy. And again, comparative studies have shown that this is as good as laparoscopic sleeve gastrectomy. We're trying to see how this can be improved further, and certainly this will be done. So I think bariatric endotherapy is going to be the future, which is going to take over from laparoscopic therapies. And of course, it's very exciting to also see that we can modify the metabolic systems using this new duodenal mucosal resurfacing procedure, that is the DMR technique, using this hot water balloon. Some early studies have shown that this is the technique which can actually decrease insulin resistance, increase insulin sensitivity, alter the metabolic syndrome. And in fact, many of these patients, diabetes also gets controlled, and of course, lipid profiles get better, and so on. So this is, I think, an area which is very exciting, is rapidly progressing. Some more data is required, but we already see that that in patients with type 2 diabetes, uncontrolled with other methods, you can see fairly dramatic decrease in HbA1c, and similarly, better urinary functions and better liver function tests. This may become the only method to treat NASH in future. In fact, all other techniques or treatments for NASH are not effective, and this may become the method. In fact, there's a recent study that the group has published in Gut showing that not only insulin resistance, the weight, the AST, ALT, everything improved after this procedure. And I think there's a lot of work going on, and further, in fact, there are further modifications to this technique, making it much more easier so that even a standard endoscopist can do this. For example, Abuday and others are using this electroporation technique, where they can actually use this to completely alter the duodenal mucosa very safely. This actually takes very few minutes or seconds to do. Similarly, we're starting to use this other techniques, and one of the techniques is to put in transiently flexible stent across the duodenum up to the jejunum. These sleeves bypass the food from the stomach into the distal part of the small gut into the jejunum, and can be removed very easily after a few months. And we have found this to be extremely useful in very resistant type 2 diabetes. So this is another area which is coming in. Of course, nodes came in very long back, more 20 years back, and this was the first nodes appendectomy that we did in a patient who had external burns on the parietis, so we couldn't go inside to remove the appendix. So we went transgastric. This appendix was removed based on the nodes technique that was coming in then. My colleague G.V. Rao and me were very enthusiastic about this initially. Unfortunately, we didn't get technology and instrumentation to develop with that. So nodes had gone into background for some period of time, even after these dramatic demonstrations. But what has been coming up is the third space endoscopy, akin to nodes, the POEM, POET, pyloromyotomy, full thickness resections, and we believe that true nodes is coming in again, because it's coming in because of the flap pap technique that we developed. And again, I believe that by 20 years time, majority of these laparoscopic procedures are going to be done by nodes procedures, which are of course going to be taken up more and more by surgeons doing flexible endoscopy. And I think this barrier between physician surgeons will certainly be broken over the next decade. And finally, when Einstein in 1929 was asked what he thinks about the future, he said, it will come soon enough. And this has happened in endoscopy. Future is coming very, very soon. In fact, what all I showed you now, I thought about a few months back was the future, but already is becoming common in use, and soon can become the standard of care. So I think future of endoscopy is extremely bright. Over 20 years, it's sometimes difficult to predict. Like Samir said, we don't know what's going to happen with the epidemics. So certainly we don't know what's going to happen in this field also. The future is certainly very good. And just to finally leave you with this futuristic concept of how we are going to treat patients with CVD stage. maybe even the US is not needed. All we require to do is a capsule that goes in like this. The patient who has a stone in the common bile duct, the robot comes up with the capsule, opens up the papilla using a laser, and then goes inside, sees this large, very large CBD stone, uses the parasite to get the stone up. This certainly is going to take more than 20 years, but I think this is something that we can look forward to. Thank you very much for your attention.
Thank you, Nagi, for this nice presentation. We want to book that capsule for us for the next coming 20 years. I don't know whether do we have any time for questions, or I think
maybe one or two questions.
Yeah. So one of the questions, whether the coming disposable endoscopes, do you think it's cost effective and the quality will be the same as the current scopes?
No, I think the quality is not bad actually. Quality is probably 80% of the current scopes that we have. There's certain limitations, but I think the major problem is the cost. With the current costs that are there, I don't think they'll be in routine use, and I think it's very, very, very difficult to justify the use unless the costs come down to, as Sham's paper showed, less than $600 or something. Then maybe there's justification. Otherwise, there's no justification.
Okay. And do you think in the coming 10 years, you'll be able to do an endoscopy for a patient while you are in India and do a patient in Dubai?
I think, yeah, I think that will definitely come, because right now we can actually look at it and do satellite. In fact, the first time I saw this was many, many years ago, maybe 20 years ago, when I saw a laparoscopic cholecystectomy done transatlantic. The surgeon was actually in New York and the patient was in Strasbourg, and they did a transatlantic cholecystectomy. So I think this is feasible. Even now it's very easy. I mean, I think the Zoom meeting, for example, you can ask somebody to be doing endoscopy and you're sitting here and watching and directing. This is an example. All you have to do is put in some more robotics or some more mechanisms and manipulate this from there. So I think this is something which is very feasible. Only thing is whether desirable, we don't know. Whether I think certainly doctors in Dubai won't like somebody from here doing endoscopy.
Okay. Okay, so thank you, Professor Reddy, for this nice presentation and interaction. I think we have to move on to the live endoscopy. Yogesh?
Yeah. Thank you, Dr. Reddy, Dr. Sham, for the nice presentation. Now we move to the next session, which is a live endoscopy transmission from Anthony Theo and Dr. Dheer from Mumbai. They will both be doing it in tandem. So the chairpersons for the next session is, of course, Samir has to stay back, and Khalid will be joining him. So Khalid is a consultant gastroenterologist at Rashid Hospital. He has been trained in Jordan, and he is a proficient in advanced therapeutic endoscopy. He's a very dear friend, and I'll invite Khalid also to take over the stage. And he will also be joined by Dr. Ahmed Zaza, who is Chief and Consultant Gastroenterology at SKMC Hospital, Abu Dhabi. And he has been trained in USA, Oklahoma, and he's a very experienced gastroenterologist with more than 25 years of experience. So the lead our experienced people to take over the live transmission.
Assalamu alaikum and good afternoon. Thank you, Dr. Yogesh, for this invitation and this wonderful conference. Our first live transmission is going to be from Hong Kong. Dr. Anthony is the head of the department. Dr. Anthony Tu Yon Pun, he is very well known. He is one of the figures in Asia in advanced therapeutic endoscopy. He is the Deputy Director of Endoscopy and Associate Professor in the China University of Hong Kong. He received his advanced training in many international centers, including Japan and United States. He received multiple awards in advanced endoscopy and endoscopy procedures. He had many publications in advanced endoscopy, including EUS and ERCP. He's going to take us in live endoscopy from Hong Kong, from his center, China University in Hong Kong. Dr. Anthony, are you with us? Hello? Hello?
Anthony, you're muted.
Muted? Okay.
Yes, Dr. Anthony.
Can you hear me?
Yes.
Yes.
Yeah?
Yes, you can.
Okay, so first of all, thank you very much for inviting me. I'm very honored to be here doing some live procedures for you guys. Let's start with the case presentation. Can we? Yeah, okay. Do you have the PowerPoint slides?
Yes.
Okay.
Testing. Okay, Ms. Fong is a 76-year-old lady who presented with epigastric pain and deranged liver function test. CT abdomen showed dilated left and white duct with knowing at Hilum, and there was also left intrahepatic ductal stones. ERCP was attempted in another hospital but failed cannulation. Percutaneous biliary drainage was also failed, and somehow PTC was inserted. So this is the CT scan showing dilated bilateral intrahepatic duct. PTC cholecystogram and cholangiogram show suspected hilar stricture. So Professor Anthony Teo will demonstrate ELCP plus or minus Van der Rohe and spyglass plus or minus laser lithotripsy.
So you've seen the history. So this patient has several problems. First of all, it's a difficult cannulation. So the plan is to do a ERCP, trying to cannulate. If not possible, then you would do a year's rendezvous. And then secondly, we need to evaluate the hilar stricture. So we're planning to do a spyglass. Her CBD is not that dilated, but we'll take a look and see if we can insert the spyglass. And we will try to evaluate the hilar stricture. And at the same time, on one of the ultrasounds, it was mentioned she has some left IHD stones. So we'll see how much stones there are, and if possible, to do some laser lithotripsy. So I think for this patient, the most likely diagnosis is probably what we see a lot in Asians, recurrent pyogenic cholangitis involving the hilum. But of course, we need to be careful not to miss any cholangiocarcinoma. Do you have the endoscopic view?
Yes.
So I think with any sort of difficult cannulation, the first thing when I insert the scope is to really study the papilla. So you can see the papilla is not too bad. I mean, there is a bit of an intraduodenal portion, but it's not the super floppy kind of a papilla. We can always turn on the NBI, and nowadays the bio usually looks red on NBI, so it may help us to find the ampullary opening easier, but I think you can probably see it's just right there in front of me. In terms of devices, I'm going to be using the Olympus Clever Cut 3. And my wire of choice is usually the 0.025 VC Glide angle tip guide wire. So let's try to cannulate. Can we tighten the sphincter a little bit? So with any sort of cannulation, I think the aim is to try to cannulate the bile duct. Looks like it's very easy. Okay, wire. Okay, it's a, okay. Anthony, can wait a moment. This is probably the PD. Can we pull back the wire? Okay, can we tighten the sphincter a bit more? So nowadays, I think the usual suggestion is to perform a wire-guided cannulation. Okay, relax the needle a little bit. Relax
Anthony,
the.
do you think clever cut? You took clever cut as your choice. Do you think that it has advantage among the other sphincterotomes?
Yes, I think so. I mean, it's very easy to use a sphincterotome. For me, it's much easier easier to manipulate device than the other sort of sphincterotomes. Okay, so I think, so for me, I think the clever cut is better. Okay, so now the wire is not really going in. I think I'm in the PD right now. But anyways, if the wire is not going in, I'm going to inject a little bit of contrast. Okay, so you can sort of see the PD. All right, so for me, the usual sequence is if there's some difficulty in entering the CBD, and if I can get the wire in the PD, then let's go do that, okay? All right, so now you see I'm trying to change the direction of my sphincterotom, relax the sphincterotom, to go along the direction of the PD. And to try to cannulate the PD. Okay, can we go deeper? Why? Your body. All right, okay, so I'm going to use a double guide wire technique. Exchange. 不如你擺條，因為我有條直 wire。好，我哋要條直 wire。Yeah. So in terms of difficult cannulation, my first choice is to use a double guide wire. Sometimes the PD wire may be hindering, may limit your movements. In that case, I will change to a PD stent. But after insertion of the PD stent, sometimes the PD stent itself can also be in your way. So for me, I'll try to cannulate alongside the guide wire first. Okay, exchange.
So do you insert the stent and then continue, or you leave the wire and maybe come back later for stenting?
So I will leave the wire first, exchange. And then I'll decide whether I need to do a PD stent. So right now, I'm not too worried because it's just only a single attempt or the second attempt. And I'm not very worried about the risk of pancreatitis in this patient. So for us, double wire first, and then if double wire doesn't work, I might insert a PD stent and then pre-cut on the PD stent. So that's my usual workflow. And if pre-cut still doesn't work, then I'll switch over to US rendezvous. So in this patient, it is a benign condition. Okay.
Anthony, how long would you try before you go to a pre-cut? Like, is there a cutoff you have, attempts, minutes, or anything like that?
Usually around 10 to 15 minutes, I will have pretty much tightened. I would pretty much have an idea whether I could get inside or not. Okay. So I think I'm in. So the double wire also helps us to identify the direction of the CBD. So I have 2 wires here. I'm probably going to pull out the PD wire. I'm not too worried about the risk of pancreatitis for this patient because it was quite a short, uneventful cannulation. All right, so let's do a cholangiogram. So I think most of the time, even if the patient had previously difficult cannulation in another hospital, a lot of times when we try it again ourselves, usually we will be able to cannulate one way or the other. Okay, so this is the gallbladder. Okay. All right, can we pull back the wire to go up to the hilum? So I'm trying to cannulate the left duct first. Okay. So we'll inject a bit more contrast. Okay. So I don't see it very well. Okay, can we pull back the wire? Okay, how about here? All right. So it seems like the right duct is quite dilated. There seems to be some stones inside, maybe. What do you guys think?
Looks there is some structure here. Do you think there is a structure? Because there is a proximal
There
dilatation.
might be a highlight structure, but it seems to be quite smooth. Okay, okay. Can we pull back the wire? Let's try to cannulate the left duct. Hold on, hold on a second. Okay, you know. Okay, so V did a great job here, but there's probably some angulation, which means my sphincter may not be able to go upside. Oh, it's going up now. Oh, nice, great. All right, so it seems that we are able to go to both sides. Right, nice. So, okay, let's do a picture. So what do you guys think?
Is there
So we can see a small structure, maybe it's, but it looks like short, very short structure.
Definitely stricture at the hilum, maybe
the hilum.
The CBD, I mean the cystic duct.
Yeah. And even the right system is not ossified.
Do you give antibiotics to all these patients, Anthony?
Of course, yes, yes.
And what antibiotics do you use? Ceftriaxone, like quinolones?
Actually, our microbiologist suggests just augmentin. Okay, hold on. Okay. So I think now I'm going to do a sphincterotomy. So exchange. All right. right, it appears that I might have lost access. Let's see if I can save this. All right, maybe, possible. Oh, very lucky. Okay, Titan. Okay.
What electrocautery machine are you using, Doc?
I'm using an Olympus.
Olympus.
So this is the endocut mode.
Okay. Does it matter to you the length of the wire on the sphincter tone? Do you pick a short one or a long one?
Of course, I try to have I try to have a short one. Relax. Okay.
Can we explain to our audience why we like a short one?
I like to have a good contact because I don't like to have a very long one. I don't want to have a short contact, a very precise cutting point on the sphincter muscles. So I think
Excellent.
now the sphincterotomy is adequate. So I'm going to plan to insert a spyglass so we can take a look. Okay, I'm going to leave the wire in situ. So this duct is not so dilated. So I think it's better for us to leave a wire here. We can always do freehand cannulation. But if the duct is not so dilated, maybe it would be easier to insert over a guide wire.
What is the cutoff for the diameter of the CBD to use a Collengeoscope, Anthony?
Well, the scope size itself, it's around 3 millimeters. So in theory, anything bigger than that, we can insert the scope. Of course, if you have a dilated system, then it's easier. And if you want to do, a lot of people just do a freehand insertion. And it'll be easier with the dilated CBD.
When you are planning to do a spy, do you try to avoid injecting contrast beforehand, just to avoid, you know, the difficulty in maneuvering?
Can you repeat that question? Sorry.
When you are planning to do a spyglass, do you try to avoid injecting contrast beforehand? Would that make a difficulty in maneuvering the spy inside the bile duct?
I don't think so, because with the spy, there is a water irrigation function. And also with the spy, there's a suctioning system. So I don't think it really matters whether you inject contrast or not.
There's a question, Anthony. Why not to do a closed cholangiogram up front to see your landmark and to see the structure and the anatomy before going to the spyglass, if contrast is not going to bother you?
Yeah, so actually I already did the cholangiogram, and the stricture is around 2 centimeters below the hilum. I think we just saw that right just now. We can always do one more with the spyglass because we can always inject contrast inside the through the spyglass.
How long you will give prophylactic antibiotic if you are using a spyglass?
Of course, yeah.
For how many days?
Usually on induction, but afterwards, if there's good drainage, you may not need to have antibiotics.
We have another issue, Anthony. I don't know how it works there in Hong Kong, because to do it as a daycare procedure, do you admit these patients or you do it as a daycare?
Yeah, so if it's an uncomplicated ERCP, like stones and things like that, we can just do it in a day case. So the patient will be admitted and then discharged in the afternoon if they feel well. For spyglass, it depends on how long the procedure is. If it's very long, then we'll observe a little bit. Why? So do you want? So you can see it's a little bit tight right there. Okay, but it went through, but it's quite snug. All right, can we turn on the spyglass? All right, can we have the irrigation on? Suction
There's
off.
a question from the floor. Is there a role of gentamicin added into the fluid or contrast when you inject?
I don't think for us we have such a practice. And if you look at all the ASGE guidelines, actually, they suggest that if you have adequate drainage, you won't need antibiotics. Can we turn on the suction, please? So do you have the spyglass image now?
Yeah.
Yeah, so it's quite clear.
If they can make that bigger and fluoro smaller, that would be good.
Okay, can we turn on the suction? On the line. Oh. Turn off Hilum. Okay, thank you. So now we have a nice visuals. So there's a big blood clot here. So I'm not sure it's because of my cannulation or there's actually a tumor here or something. But anyway, we'll try to suction. I'm advancing my scope, the spyglass, to see if I can go beyond that. The spy is at the Hilum district level of the stricture. I'm going to try to advance it a little bit more. Okay, I'm going to advance it a bit more. I'm losing my scope position, which is not good. Okay, seems like there's a lot of blood clot here. I'm going to pull back my spine now. Okay, do we have a suction? Okay. So I don't see a obvious tumor right now. Okay, can we turn off suction? Seems like the blood clot is being washed up by me. There seems to be a smooth stricture. What do you guys think?
If you're in good position, maybe if you remove your guide wire, then it will be more better to wash and all this
Yeah,
stuff.
well, I can remove my wire, but you can see my spy. I'm really losing position. So what I think I need to do is to recannulate and then reinsert the spy. All right, let's
The
change
question of the spyglass, better to be operated by two or single operator? What do you think,
back.
Anton? Especially with these difficult cases.
Yeah, for me, I always do it on my own because I don't have always have someone helping me. Of course, you can have two persons doing it. It's like the way that we used to do a mother and baby Collengeoscope. I think both options is okay. Oops. So this patient seems to be easily dropped. It's a bit unstable position.
Khalid, I totally agree with you. It becomes a burden with a case that is difficult like this. But the advantage of a spyglass is just it's a one-man operator than having two people in the room,
Okay.
which becomes crowded sometimes. But
Let's try to cannulate with the spy. Thank you. All right, now I have a good position. I'm going to be a bit lazy and try to see if I can cannulate without the knife by freehand. Okay, thank you. All right, I'm going to try cannulate with the spy. Oops, okay, it's going up well. Looks good. Okay, I'm going to just go by freehand this time, listening to you guys. We change back to the spy. Stop suction, please. Off the alarm. This is the level of the stricture. It seems to be quite smooth and no definite tumor. Okay, I'm going to try to go past the stricture. Okay, I've gone through it now.
so what do you think the etiology of the stricture is?
So can we turn on the suction? Thank you. Yeah, in Asians, we see a lot of them with what we call a recurring pyogenic cholangitis. So these patients actually had a primary inflammation of the intrahepatic ducts and with IHD stones. So now I'm struggling to get a good view. I'm going to check my scope position. I'm probably facing the wall a little bit.
Anthony, what do you use for flushing for everybody to know? Do you use normal saline?
Yeah, so it's a saline inside the scope.
With a flushing pump.
Yeah. So I don't have a great view. But I'm trying hard to clear up for you guys. All right, I'm probably just at the stricture. All right, so I'm not seeing much. So let's do a contrast.
Anthony, there's a question. What about doing a EUS before cholangioscopy for evaluation of hilar stricture?
Yeah, that's definitely something we can consider. But nowadays with spyglass, I think it's I think if you see anything on spyglass, it's better that way for us to actually do biopsy from the cholangioscope than to try and get a US guided biopsy. So right here, somehow I think I see a lot of IHD stones, but I'm just not getting a very great view. Okay, I'm gonna try to manipulate my scope a bit more. All right, so maybe let's see if this way. All right, okay.
Maybe more irrigation of water.
Yeah, that's what I'm doing. Okay, interesting.
This is ulcerated lesion, is it?
I don't think it's really a malignant lesion. I think that's probably some spy scope associated trauma around here. You can see some stones right here. Oops.
Stagnation proximal to the stricture, sometimes it gives you sludge and the stone, and you need to be, sometimes we need to be very careful that not to miss malignant stricture.
Yeah, yeah.
What do you think, Anthony?
Of course. So there seems to be a lot of stones here. I'm almost below the stricture. Can we do some suction? But so far, I'm not seeing a really suspicious malignant lesion. What do you guys think?
I agree, but I would still take a biopsy. Would you rather take a
Of course,
biopsy
for
or
sure.
just, yeah?
Yeah, for sure, I'll take a biopsy. So here I'm trying to go inside the left system. Let's see if it's possible. It's quite angulated, so
Be careful about your position of the spoon.
yeah, it's not easy. I'm dropping again. Okay, I'm dropping again. All right. I'm losing position again. I'm probably gonna try to get some biopsy here. Since I'm under stricture, can we have the spy bite? Capture. Spy bite. 이거 멍멍멍 들고 저거. So the spy bite itself is a very small biopsy forceps. So again, we need to get a few bites in order for it to have a nice catch of the tissue. So now I'm right at the angle of the scope. You can see my bite right there. So I've just inserted my spyglass a bit more deeper so that it can negotiate the band a bit easier. Okay, can we open the what's that? All right. Oh, ow. Let me capture this.
What are the characteristics of malignancy on morphology on spyglass, Anthony? There's some classification
that's a good
for
question.
the viewers.
That's a good question. So we are off the kind of things we look for. Again, is very similar to what we try to look for in MBI: abnormal blood vessels, irregular mucosal surfaces. So right here, we're seeing some irregular mucosal surfaces, but we don't see very abnormal blood vessels. So it's hard to say.
Anthony, how many biopsy you will take with this small?
At least 3 to 4. So again, right this it's a bit difficult for me to insert the spike bite. So I push my scope a bit deeper again. And then I pull back my scope. Okay, open. Ow. Ow. Okay. Again, I got a good bite. Thank you. So after my spike blight, the plan is to, I try to insert 2 wires, left and right ducts, dilate the stricture, and then see if I can insert 2 pigtails, if possible. Sub French. Look, mm.
Sometimes with this position, it's very difficult to put the forceps through the spyglass. What is your way to avoid such difficulties?
Can you say that again? Sorry, I can't hear you.
With this position, sometimes very difficult to insert your biopsy forceps inside the spyglass.
Yeah.
Do you face some difficulty sometime?
Yeah, so I will show you again just now what happened. Ow. Cho thôi. Ow. So now it looks more papillary. Huh? I'm not sure whether this is a benign or malignant stricture.
Maybe it's malignant and broken otherwise. What do you think?
Right, so I'm going to insert one more time. So the usual difficulty is at the bend. So I'm going to insert my bite all the way to the bend. Okay, you can see on X-ray the bite is right at the tip of my endoscope. I'm going to move it a little bit. Can you see the spike bite in the channel? Can you see it inside the scope?
Yes.
No?
Yes, yes.
Yes, yes.
Right here, okay? So I'm going to push it further. Now I cannot push it anymore because it's right stuck at the bend. So what I can do is to insert the bite a bit more deeper. And then I'm going to insert the spine a bit deeper. And then now I can push the bite out because I've gone to the bend, and if I push the bite a bit more, then it actually helps me to negotiate the bend. And now I can push it up through the channel. So that's my technique.
And that really answers one of the attendees' question about what kind of technique do you use to insert the spine bite biopsy, or even when you're using laser, is just moving the whole spine bite through the angulation and then moving your instruments inside it.
Yeah, correct. All right, so since I don't have a very good view upstream, there are some stones. I'm gonna go remove my spyglass and then change back to my ERCP scope and dilate the stricture and put in the bilateral plastic stents.
Anthony, if it is okay, can we move to Mumbai, and Dheer can demonstrate some cases, and then we come back to you?
No problem. Yes.
What's your plan? Are you going to put a stents here, or?
We're going to put in 2 plastic stents, left and right.
Okay. So I think we can break and go to Mumbai and then come back to you. Is that okay?
Yeah, for sure. Thank you. 左右。
Good afternoon, Yogesh. Can you hear me?
Yes, sir. We can see you and we can hear you very clearly.
Hi, hi. So I was watching this wonderful demonstration of SPY by Anthony. A fantastic case, a really difficult one. And I hope you all are enjoying it. So welcome to Ideal Care Mumbai. We will show you two cases, starting with a very, very simple, straightforward case. I discussed with Yogesh that I would like to show simple cases than complex cases because they are more useful in clinical practice. So my colleague, Dr. Priyanka, will give you the history of the first case. Priyanka, if you could please give the history.
Hello, everyone. This is the case 143-year female. She presented with 4-week history of abdominal pain, weight loss, and nausea. Blood parameters were normal. CA and CA19-9 was also normal. CT scan showed heterogeneous paraduodenal region, measuring 6 into 4 centimeters. Lesion with lots of fat planes between the duodenum and pancreas, and DOTA scan was positive. So now we are posted for US guided biopsy.
Okay. So this patient is a very interesting patient. A short history of weight loss and pain, a paraduodenal, peripancreatic mass. But what is not given in this history is that the DOTA scan also showed uptake in the stomach. So what I will do is I'll quickly do a gastroscopy to see what is happening in the stomach before we start with the EUS and biopsy. So we quickly go into the stomach and see what is the stomach like. So I see residue. I hope there is no major obstruction at D1, D2. She does vomit intermittently. So there is some residue here, as you can see. So we suck this out. So she doesn't vomit every day, but she has. Now you see the mucosa, underlying mucosa. Yogesh, can you see it?
Yes, yes, sir. We can see it very clearly.
It looks grossly abnormal, right?
Yeah.
So these neuroendocrine tumors are very, very interesting. You can find them all over the GI tract. Now see here, we have this lesion. If I do a NBI, see this looks hyperplastic to me, but the surrounding mucosa is definitely not normal. See this? This is grossly abnormal mucosa.
Yeah.
And it extends in the entire body along the greater curve and also going on to the fundus. So what could be the possibilities? Is there a problem of achlorhydria and then you have hypertrophy here? See, these are
Neuroendocrine tumor.
Hello?
It is, yeah.
Neuroendocrine tumor.
Possible, yes, yes. So this stomach is not normal, definitely not normal. And why is there a little more residue than what we normally see? Let us see if there is a partial, at least, outlet obstruction. So we go into the stomach now, or into the duodenum. And here, see this? Again, you see abnormalities. This looks proper infiltration at the D1, D2 junction. And then let's try to go into the D2 if we can. I will not cause too much trauma. I'll just try to gently see if I can go into this or no. So I think it is probably difficult to get into the D2. Okay, we are in D2. Now you see the D2?
Yes.
Multiple ulcerations. See this? A very interesting case. Maybe I should do serum gastrin in this case to see if there is any gastrinoma kind of thing.
Yes.
See this? There are multiple ulcers in D2. Erosions more than ulcers. We slowly withdraw and see these linear erosions in D2 on the folds, and you have this impression here at the D1, D2 area. So I think we should do some more biochemical investigations. This can be biopsied, of course. See these areas? These can be biopsied to see what is going on. Looks like a very diffuse kind of neuroendocrine disease. Biopsy, please. So I'll quickly biopsy from here as well as from the stomach. Then we'll do the EUS. Is that okay? What is the opinion of the house?
Yes.
Sure. Is there a DD for lymphoma, sir? Doesn't look like, but.
See the folds are not thickened, but lymphoma is one of the possibilities. But I would be thinking more of lymphoma if you see gastric fold thickening or something from the stomach extending into the duodenum continuously. That would be lymphoma for me. This in the stomach, it looks more like hypertrophies and probably some, as was mentioned, a neuroendocrine kind of thing. Open. So we try to take a biopsy from here. Close. So management of neuroendocrine tumor has evolved very rapidly over the past few years, and you have so many therapies depending on what is the extent. So you see here, you have these nodules here.
Everywhere, yeah.
Extending all the way.
Hasn't the detection also increased recently because we are picking up them more? We are seeing more often the neuroendocrines. I think the gastroenterology is also more aware. We are biopsying more.
Yes. You are right. Absolutely right. What is the situation in UAE? Are you seeing more and more cases?
Yeah. We are picking up them everywhere, in the stomach, in the pancreas, in the rectums. Yes.
So we'll sample the gastric mucosa also to see what is going on here. And the duodenum, I'm not very keen. I would take, because I'm going to take the EUS biopsy anyway from that area. But this is very, very interesting. I want to know what is happening in the stomach. Open.
Atrophic gastritis, sometimes associated with the neuroendocrine type 1.
Yes, you are right. Sometimes it could be just a hypertrophic gastritis. But very, very interesting. So now I'll come out and we'll introduce the EUS scope, and I'll show you the EUS picture of this lesion. So we see several NETs every month of different kinds in all organs coming from the stomach. Stomach, of course, is the most common. Many of our patients, बंद क्यों हो गया section? Section is gone. Achha. So NETs, we see many patients who have atrophic gastritis, and then US. They have NETs. Then you see NETs which are like a solitary submucosal mass in the duodenal bulb that you all must be seeing pretty commonly. And then there is a very interesting situation of you have NET, multiple NETs, like this case. You have NETs in more areas than one, and then they become very, very challenging as to how to manage them, because obviously surgical resection is not an option. You will need a very huge resection. So you have to think of how to manage the diffuse kind of neuroendocrine tumors. The presence of duodenal erosions in this case gives rise to one more possibility, whether that paraduodenal mass that has been seen on CT is a gastrinoma, and what we are seeing in the stomach and the duodenum is probably the effect of an increased gastrin secretion. That is another possibility I feel we should entertain. What do you say?
Yeah, that's a possibility, sir.
Yeah.
So
we are
like
just
you said,
changing
there's a
the
role
scope.
of doing a serum gastrin and chromogranin in this patient for us to know what's happening biochemically.
Very right.
And as also Dr. Rajiv is suggesting from Australia, we should do a anti-intrinsic factor and anti-parietal cell antibodies for the workup.
Yes, absolutely. So this is more a physician's case than a surgeon's case.
Do you normally do the chromogranule level to begin with, or do you add other markers for the neuroendocrine tumors?
Right. So chromogranin is high in this lady. So I am using a linear EUS scope. Those of you who were there when I talked about linear EUS yesterday, you can see my hands. This is how I hold my scope. I'll give you very simple. Okay, where is the camera? Can you move the camera, please? Bibin. So here you see, I introduce, you see there is a ultrasound at the tip of the scope. So you have to be very, very careful. You go in gently, bend the scope, go behind the cricopharynx, and gently introduce. So in this case, there's a little resistance to passage of the scope. So I'll ask although I have just passed a gastroscope. So I'm in. Show me the EUS image, please. Yeah. So I am in. You can see that I am already at the heart position. I'll come back a little. I'll quickly show you how I do it. So once I am in the esophagus, what I do is I rotate my scope. I rotate my scope. You are seeing my hands, and I continuously suck. And I try to, in this case, I have done a gastroscopy before, so there is a problem of air, but I try to get both layers of the esophagus in one view, please. So now you see here, you have two layers of the esophagus. This is my transducer, and this is the anterior wall of the esophagus, and this is the posterior wall of the esophagus. So this allows me to do a very quick assessment. You see, you are seeing two layers of the esophagus now, and there is air in between. I'm gently going in and assessing the mediastinum as I'm going in. So this allows me a very quick assessment. See, this is the G junction. Can you see? This is the G junction. Exactly like a coronal section on CT scan, you see the the G junction on EUS. So all you have to do is rotate your scope in such a way that you don't see one wall. In linear scope, we are taught to just concentrate on one wall. But if you rotate your scope in such a way that you see both the walls, then you are seeing the esophagus like you see it in the sagittal sections of CT scan. See, this is a complete esophagus that I am traversing. And anterior, you see there is a trachea. See this? This is the trachea. This is the aorta. And if I go below, you see the heart. But you can see the periesophageal structures beautifully, like this. So this you will not find in a textbook. This is what I do in my practice. And see how beautifully you can see the G junction. You can see it exactly like how we see it on CT scans. So this is the G junction. Once we go in, you see the liver. See, this is the liver. What I do for the liver is, I turn clockwise, I see the IVC, then turn little anti-clockwise, I see the hilum, and then I turn more anti-clockwise and introduce a little to evaluate the left lobe of liver. So here you see this is the left lobe of the liver. I'm evaluating it. Just concentrate on my hand movement. They're not much, but you see here, this is how we go. It doesn't look like there is any metastasis in the liver because we are suspecting neuroendocrine tumors. You should look for metastasis. So a quick examination of the liver is done. Then let us turn clockwise and try to identify the liver hilum. See this is the hilum. See this is the portal vein which is going into the liver. Doppler, Gumau, please. So now here, what you are seeing is the portal vein and the common bile duct. The bile duct entering the hilum, here it divides into right and left, and this is the portal vein. The bile duct doesn't look dilated. I will quickly measure it. 5 millimeters. So it is normal. So I already know that since the intrahepatic biliary radicals are not dilated and the bile duct is not dilated, that there is no obstruction. See this? I just went half a centimeter in, Doppler. You can see the bile duct now, Yogesh?
Yes, yes, sir.
So this is the bile duct. See here, I'm tracing the bile duct gently, and now I am on to the head of the pancreas. You are seeing the bile duct behind the head of the pancreas. See this? This is how it is going. Here. So gentle movements. I am doing millimeter movements.
Oh,
Doppler band kar do. And very close to it, you see this big mass. So this is a paraduodenal mass. Freeze. See this? There is a big mass here. This is 5 centimeters. Now, if you concentrate on these white line here, see this white line? This is the duodenum. This is D1, D2 area. We are seeing from the stomach. So obviously this mass is in relation to the duodenum. So it is a peripancreatic. This is the head of the pancreas. Paraduodenal mass. And this entire line is the air in the duodenum. See this from D1 to D3. So this you can see from the stomach. Chodo.
What is the role of contrast enhanced EUS patient?
Practically very little, only in cases where you are not getting your biopsy in the first go. I would try to think of contrast, otherwise no. Now see this, what is happening here? This is the mass, right? See, there is a big mass here. I turn little clockwise and I see the superior mesenteric vein. So it is not involving the superior mesenteric vein. I turn little more, freeze. And what are you seeing here is the aorta. This is the aorta. This is the celiac axis. And this is the SMA. This is the left renal vein here. And this is the uncinate process. So yesterday I was telling you how to look at the uncinate process. This is the classic anatomy of uncinate process. Aorta, celiac going up, SMA coming down, and in the angle between the aorta and the SMA, you look at the left renal vein, which is in the angle here, and underneath that, you see the uncinate process. Looks normal to me, Chodo? Was that clear, Yogesh?
Yeah.
Huh?
Sure,
See
sir.
this.
Yes.
Very nice. Very nice.
Very nice. Just like a textbook.
Thank you. So see this is a big mass. And yesterday I told you about biopsy. Now that we have seen the mass, you feel like you want to take a biopsy from here, but you should not, because there is a big vessel between your transducer and the mass. So for taking a biopsy, you should go to the duodenum. So we have established that this is a mass which is not arising from the pancreas. It is not, it is in relation to the head of the pancreas, but it is not arising from the pancreas. It's a very well-defined mass which is separate. Now quickly what we will do is, we come back, see this is the head, and now I turn. Yesterday I talked about the alpha loop. I turn from here and look at the body and tail. So these are the splenic vessels. I turn clockwise gently. See, this is the body and tail of the pancreas. You can see the pancreatic duct is also normal. So bile duct and pancreatic duct both are normal. Pancreas is normal. So we know that this mass is not in the pancreatic head. Please. So this is the left adrenal. You can see this bird-like structure here. Chodo.
Seagulls.
More clockwise. Sorry, see this? This is the left adrenal. More clockwise, more gentle withdraw, keep tracing the tail, and you are coming to the splenic hilum. See this? This is the splenic hilum. So the pancreas is perfectly normal, and you have this mass. Endoscope. Now what we will do is, we will try to go into the duodenum. I hope we are able to go. Okay, we are in the bulb now. Let us see. Dikhao. I don't know whether we'll be able to see the mass from the bulb. Right now it is all air. See this? In patients in whom you do gastroscopy before, please. So this is the head of the pancreas. This is the portal vein, splenic superior mesenteric. So this is the head of the pancreas. Okay, Chodo. And as I am withdrawing, I see this huge mass. See this again? Now here, the advantage is that there is nothing in between the mass and the duodenum. Doppler, but we should do Doppler. Okay, I think there are some thin vessels, no major vessels coming here. So this is like In India, we have laddus. So this is like a laddu. So round, beautiful mass, easy to biopsy actually, provided you see that there is no vessel intervening. Okay, now we'll take a quick biopsy from here. We will use a core biopsy needle because we will need molecular analysis in this case, neuroendocrine tumor, lymphoma. So this is not the usual adenocarcinoma. So we use a 22 gauge acquire always. Needle, any FNA needle has 3 parts. It is a hollow needle which has a stillet inside the hollow and a sheath outside the needle. 3 parts. The sheath and the needle can be controlled from outside. You see these buttons on my hand. Can you see these buttons? So the upper one is for the needle. I don't use it, so I'll leave it loose. The lower one is for the sheath, which I use just to see if my sheath is in position. Because the scope is bent, so I have to see whether it is out or not. See that? Now I can see it out. So I lock it, take it out still further. The blue mark, you can see the blue mark there from there where the needle comes out is important. Once you are there, then you focus once again, fix your scope properly and puncture. I am in.
What about locking the controls, sir? What some people lock, some people keep it loose. What's your policy on that?
So, you know, locking the controls loses the subtle movement that you want. So I never do that.
Even just before the puncture, you will not lock it?
Never. Because I want my small movements. See what I am doing? Very, very millimeter I go in. See, I change my elevator. Go in again, come out, change with the up down, go to a different area, take the biopsy from there. All the while Vikas is gently withdrawing. See? And you should not be in a hurry. Do it very lazily. Even the puncture should be very gently. Allow the needle to scrape the tissue. Don't just quickly jut in and come out. I have seen people doing fatafat, 8-10 movements. That only causes more blood. So be gentle, be lazy, and I think we are done. Let us see what tissue we can.
What is the number of strokes you would say, sir? How many strokes you would
It is
say?
subjective. It is really subjective. 95% of my cases I make only one pass. This is I call one pass. And I don't use numbers. I try to see that I have taken a sample from different areas of the lesion. So you use fanning and try to take once I'm happy that I have gone into quite a few areas of the lesion, I finish. I don't count how many times I have gone in. And I try not to go into the same area more than once. Because first time you go in, your needle goes in that. Once you withdraw the needle, the track is filled up with blood. So if you go in the same area again, you are only aspirating blood. So don't go in the same area again and again. Of course, sometimes it is not possible to change positions, in which case that's a practical issue, which I am.
You're using full suction, partial suction, or no suction?
No, you withdrawing the stillet gently. Keep it in a bottle. Don't keep it in that round thing. And show the bottle. So we'll show you what tissue we have got.
So you are collecting it in a cytolite or formalin or on a slide?
It goes in formalin.
Protocol?
It goes in formalin.
So
Dr. Bosch.
Entire sample goes into formalin, or you keep something on the slide and then?
Oh no, nothing. Entire sample goes in formalin. Go there. Can you see
Focus?
it? Move it. पानी और डालने का था ना यार.
Yeah, we can see some tissue. Yeah.
There's 2 core pieces there.
Yeah. Thank you, Rahul. Looks good. Yeah, we can see a core down there at the bottom.
So one biopsy is enough. In this case, we don't need to take any more biopsies. So, you know, it could be gastrinoma. I am thinking in terms of gastrinoma. Let us wait for the biopsy. I'll also send serum gastrin. And any other questions here? I'll be happy to answer while we prepare the second case in the next room. So there is a partial kind of outlet obstruction. You see this water in the stomach?
I don't have an endoscopy view. We lost it.
EUS view, please. Give the EUS view, please.
Can we have endoscopy view?
No, no. Look at the EUS view.
Yeah.
See,
yes.
It gives you more information. It gives you fluid, and it also tells you that the gastric folds are not hypertrophied. That goes against gastrinoma. Normally, the gastric folds will be hypertrophied. See, on EUS, you are not seeing hypertrophic gastric folds, right? These are normal gastric folds that we are seeing.
Would you consider biopsying any of the smaller lesions from the stomach that you saw earlier
So
on?
I biopsied the surrounding mucosa and I biopsied the duodenum. The small lesions, I was thinking if need be, I will take them out in toto and not, you know, just biopsy them because they are really small.
Yeah.
So we can do a polypectomy of them. Some of them look like hyperplastic polyps on NBI. So you see here gastric wall. We have to also see if we are thinking of gastrinoma, whether the wall is thickened. Doesn't look grossly thickened, mildly thickened. Freeze. Is there anybody? Freeze karo bhai. Now if I measure it, see here. This is the gastric wall. It is 10 millimeters, so it is thickened. It is definitely thickened. So very, very interesting case. We really want to know what is the pathology in this case. And she has lost a significant amount of weight, significant amount.
Sir, in the meantime, we'll have change of guards here. We'll invite new chairpersons. The previous chairpersons also requested to stay back. So I would like to invite Dr. Kadri, who is who has done General GI Fellowship from University of Wisconsin and Advanced Therapeutic Endoscopy Fellowship from St. Lucas, Milwaukee. He was the director of North Florida Gastroenterology Research Center. He is the director of VPS GI Services and is also a chief therapeutic endoscopist with Advanced Center for Daycare Surgery, Abu Dhabi, a very dear friend and very accomplished therapeutic GI endoscopist. Kadri, welcome.
Thank you, Yogesh.
And
Thank you.
I will also like to invite Dr. Madhav Mukunda. He is a gastroenterologist at Mediclinic Align. He has been trained in India from Trivandrum, and he is in Align for last 4 years. And his main area of interest is ERCP and therapeutic endoscopy. Welcome, Mukunda.
Hi.
And Dr. Matthew Madhukut, he is the head of the department, gastroenterology at Life Care Hospital, Musafa, Abu Dhabi. His main area of interest is ERCP, therapeutic endoscopy, and he is an avid researcher, and he has a lot of interest in clinical research and liver fibrosis area of clinical research in that. So welcome the new chairpersons, and we'll take over to the next case. The previous chairperson, please stay back. We'll need your valuable inputs during this meeting. So we'll have one more case from Mumbai, and then we'll switch to Hong Kong and see what Anthony is going to show us. So next case, Dr. Dheer. So to kick in, I think Khalid is here, Kadri is there, Dr. Zazar is there. For EUS, do you guys still are using any of the FNA's needle for a mass lesion or something, non-cystic lesion? Are you using any FNA needles, or you have stopped using them anymore?
I mostly use F&B needles.
Yeah, no more FNA. I guess the FNA is dead unless there are certain circumstances that you use it for. And we're mostly using the acquire.
What about you, Khalid?
Why? For FMB mail. For mass.
Okay, we can have a second case.
Now we'll be presenting the second case. This is 27-year-old female, known case of chronic calcific pancreatitis since age 15, and known diabetic patient on insulin. She had come to us in June 19 for ERCP and PD stenting, and during ERCP it showed stricture in head and dilated PD beyond. That time basket fit was done and 7 French PD stenting was done. Repeat ERCP was done on October 2019 and stent was removed. Since then, patient was asymptomatic, but in 2020, again, she was suffering from repeated episodes of acute pain abdomen.
चल दे दे मेरे को यार खत्म कर.
So the MRCP showed stricture in the head. Slides are not moving. And because of then again we repeated the ERCP, and this time cannulation was failed. No wire was going through the stricture. So we planned pancreatogastrostomy. Now but we giving the case to Dr. Deep for live demonstration.
Can you see me? ये light चालू करो ऊपर.
Yeah.
Can you hear me? Can you see me?
Yes, we can.
We can see
can
as
hear
well as
you.
hear you.
Okay. So did you get the history properly?
Yes.
Yeah.
Could you hear it clearly?
Yeah.
Yes.
A little bit, but we got the history, most of it.
Okay. So this is a young lady of chronic pancreatitis. We did an endoscopic stenting and she responded very well. And so we removed the stent. But she comes back again after a year. And this time we cannulated the pancreatic duct. We did the ERCP. But there was a very tight stricture. And we could not pass even a wire. The contrast also was not going. And the wire also was not going. So we thought, if possible, we'll see if it is possible to do a EUS guided pancreatogastrostomy. So there is some residue in the stomach. I'll suck it out. She's a little unhappy. Air nahi hai. Air do. Yeah. So I am in the stomach. Here, she is hiccuping a little bit. And let me see that everything is okay. We'll suck out the air and then try to see if we can see the pancreas. So I start withdrawing from the antrum. You see, this is the gallbladder. I turn clockwise. Keep withdrawing.
Can we have EUS image, please?
Yeah, we're not seeing EUS image yet.
EUS image, please. That is a CM. So can you see the pancreatic duct now? I think I'm seeing pancreas. This is the pancreatic duct.
Dilated.
I keep withdrawing till I get a good Doppler. I think this looks like a nicely dilated duct. See that? Can you see the duct?
Yeah.
It is very thick walled, extremely thick walled duct. Chhod do, band kar do Doppler. But I will not puncture till she stops hiccuping, because I don't want my, see there are vessels around. So this is a dilated duct. You can see stones here. There are stones inside. And there
Could you
is
not
atrophy
do
also.
this procedure under general anesthesia, Dr. Dheer?
So we use propofol.
Okay.
Propofol is what we use. And sometimes they are unhappy, so they, they keep shouting. So I would not say this is an ideal case, because there is dilated pancreatic duct, no doubt. We can puncture it, but I am seeing stones inside. And I feel there is some atrophy in the pancreas also. So see this, so many stones are there inside.
Layering.
Stacks of.
Yeah, stacks of stones. So I can do it technically, not an issue. We can try puncturing the pancreatic duct. Can we turn her flat? Why is she not happy?
So probably the ERCP could not be performed because it impacted the stones there.
No. There is a very tight stricture. We got an MRCP done.
Okay.
There is a very tight stricture beyond which even the wire is not going, contrast is not going. So we did the ERCP first, actually, thinking that we'll be easily able to pass through, because we had done the ERCP in the past, but we could not pass anything. So then we did the MRCP, and we found that there is a tight stricture. Now this is the pancreas. See, there is a stone here. Multiple stones, lots of stones. I am really thinking whether I should do or I should not do. What is the suggestion of the house?
I mean, you've already tried the ERCP to drain this unfortunate 15-year-old. That's your next choice.
See, lots of, there is a
until
bunch of stones.
Will it benefit her?
The pain will go away.
Of course.
Pain will go,
yeah,
definitely. But it's no long-term solution. We need to do something for the...
plan for surgery in the future? Surgical
You won't be able to remove these stones, isn't it, sir?
We can, we can pass a spy scope through after we dilate to 10 mm. But, I'm a very conservative person. I'm thinking whether we should send her straight for surgery.
Unfortunately, in my experience, these pancreatic duct strictures are very nasty, and even putting multiple simultaneously placed stents, and after giving them ample time and removing them, these strictures tend to recur, and patients ultimately require surgery.
So, what is the opinion of the house? Should I try puncturing or should I leave it?
I mean, you're there, might as well.
Let me see. What I will do is, I will not try very hard. I will make 1 or 2 punctures. If I don't get the duct, we will come out. Is that okay? Is that a good?
Yes, perfect.
Via media, we will not try very hard. So let's go back. Now that we have changed the position, I have to go back again. Endoscope, please. So now I have changed the position from left lateral to flat. She's lying on her back now. And that is done so that it helps my fluoro. So we turn clockwise and try to see the pancreas. We are already on the kidney. Why is the scope falling so fast first? Okay, yes. Kidney. Gallbladder. Aorta.
Now, just a quick question.
2 minutes.
The initial structure was just in the same place as you are seeing the next structure now?
Yes, yes, exactly the same place. So now I am trying to get this in position. I am not seeing the duct because I changed the position of the patient. So give me 2 minutes. So this is the hilum. We turn clockwise. That is the pancreas. See there. So this is the, it's a very acute angulation. Huh? I think we better turn her back to left lateral because ये position change करना में the whole thing has. Give me 1 minute. You can see the stones now, right?
Yeah.
Yeah.
This is the duct. Now I am tracing the duct. Fluoro. It is also a good pointer to do fluoro to see that your scope is not in a very bad position. It should be looking toward the head. So see, this is the stones here. Okay. Scope पकड़ना पड़ेगा. दीपक किधर है? Trying to get a good position so that I can puncture safely without creating much problems to the patient. पकड़ा? अरे 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 क्या कर रहे? हिल गया पूरा. Fluoro once again. Or patient is very unhappy. CO2, CO2. Huh? Yeah, Yogesh, your idea is sometimes I think we should maybe do a general anesthesia. She is very unhappy. She's moving, she's hiccuping. Okay,
Yeah, it
पकड़
can
सकता है
sometimes
ऐसा?
be risky in such a
Yeah, mainly
advanced
situation to puncture at this time if she's moving a lot.
Needle. So we are using a Boston Scientific 19 gauge needle. I will not make too much effort. Huh? I will just make 1 or 2 punctures. If it goes fine, otherwise she is referred for surgery. पोजीशन चेंज कर दिया तूने दीपक हिल गया ठीक है 1 मिनट छोड़ तुम लोग ना क्लॉकवाइज घुमाते रहते हो पेशेंट को उसको so see the position is also
you are at the
unstable.
G junction, Dr. Theer, isn't it?
I am in the proximal stomach at about 43-44 centimeters. This is the aorta, you see, and in front of the aorta I should see the pancreas.
That's a better view.
That's yeah.
Complex one. This is complex one. This is not an easy one.
The teaser. And
That's why she was referred to you.
No, she's, she's following up with me for more than 2 years now. She was very happy after the first, what we did the first time. She had almost a year of pain relief. But this time, I think she delayed it a bit. She just got married, so delayed it. And she,
Maybe Corona has to be blamed also.
Yeah. So she came and we are not able to pass anything. Maybe I will, and I'm not really finding it a great position. You should normally see a nice, beautiful
right.
duct. Then only we should puncture. Otherwise, we'll go here and there. Chronic pancreatitis patients will have lots of vessels here and there. I don't want to cause problems. So one last attempt. Endoscope. दीपक तेरे ही ऊपर है सब. तो गड़बड़ करेगा ना तो सब क्या हो रहा है ये? Give inflate. हाँ, see, you're in a wrong position. Let's go back. Needle too much out. Let's take the needle little in. This is good. So we suck the air, turn clockwise. Can you turn her left lateral? So we are again turning her back to left lateral. I am hoping that we'll get a better position.
Those cases with stricter secondary chronic pancreatitis. Can you hear me? Hello?
Yeah? I can hear you.
Yeah, putting more than one stent rather than removing the stent from the beginning will be, do you think that will be better options?
So normally what we do is we put a stent and then if the patient is pain-free, because I don't like to keep pancreatic stents for a very long time.
They can cause more strictures.
So if the patient is pain-free for 6 months, we remove the stent. So that is what is a normal protocol we follow. And then, because we removed the stent and after that she was very okay for 1 year. So the idea behind removing the stent was not wrong, but the issue came back again. And this time it came with a vengeance, very tight stricture. It could be because there was a stent already in position for a year, so that area became even more tight. I don't know. But here I am not happy at all. Kidney. Pancreas. This is the pancreas, as you see. You can see the stone here. And then when I try to see, this is the duct. Can you see the duct? Bada kar do aur. See, this is the duct with stones.
We see multiple stones there.
I'm trying to trace it in a where I can get something to puncture. This is also there. See, because if I puncture through the stones, I may not go in.
May not help.
See, this is a stone. It's almost like a cord. See that? You can see the duct almost like a cord. ऐसा पकड़ सकते हैं? उधर देख रहा है ना तू? नहीं, already change कर दिया. फ्लोरो चेंज करो. नहीं, इधर ले. ओके. खैर, मेरे को ना ये ऐसा चाहिए. तुम दबा घुमा मत. So these are the talks going between me and our colleagues here, and they are indispensable
That's
to
a
what
very
I do.
important part of a procedure. The communication has
Yeah,
to be.
without them I can't survive, you know. Naya and Ilna? Sure. Okay. Floro?
Very hard.
Risky, very risky. See, the pancreas is very hard.
Not very easy to puncture with the 19 gauge also.
I am at the wall now. I'm right at the wall. But to puncture the wall, you see it is denting the wall. You can see?
Yeah.
It is denting the duct
going
wall. See
inside.
that? So one more big push, one last push, huh? Yogesh, after that I'll give up.
Okay.
I don't want to trouble her. Okay, hold like this. I am locking all the controls so that my scope doesn't jump back. And now let us see what we have done. See, this is risky because you can puncture a big vessel. But I have not moved. See, I am just there. You saw?
Yeah.
I am still at the level of the duct. It has not gone inside at all.
Sir, will using a, sorry, I'm disturbing you.
Huh? Give me a Olympus needle.
Yeah, a 22 gauge needle and then using a 018 wire or something like that, through that?
So, yeah, that's a good method. Unfortunately, 018 is not available in India. I don't have it. So, otherwise, you can use a 22. And I tried 018 in a few patients. It lasts even not even half the procedure. It is very soft at the tip and it completely coils and finishes off. So, very delicate wire. I have been asking these VisiGlide guys to make something in 018 because that will be useful not only in pancreatic duct but also in the bile duct. Because when you do hepaticogastrostomy, sometimes the intrahepatic biliary radicals are not very dilated. In that case, what you say is true. You put in a small needle and inject so that they become big and then pass a very thin wire.
Here it is a double trouble actually. Through the stomach is difficult and 19 gauge is such a big needle and such a hard pancreas. So I think
You're right.
A cocktail.
So I am changing my needle, hoping that it will work.
Easy shot?
This is, yeah, easy shot 3. Okay, one last try. We should also know when to give up.
Absolutely.
That's the most important step for endoscopist.
Yes. Now you see the duct. All of you are seeing the duct which I am aiming. Looks like we are in somewhere. This went better than the earlier needle, but I don't know where we are. Hmm.
It's close.
Yeah. Still butting against the wall, looks like.
Just hitting the.
Yeah.
So because the duct wall is very thick, it just bounces there.
Because it's going tangentially also.
See, it just doesn't, this thing just doesn't go inside.
Is it in?
Yeah, it looks like it might be in the.
It's, no, only in the wall. It's not in, freely in.
Yeah.
Freely in is very, you can know, you know that you are in now. It's just in the wall. Okay. छोड़ो. हाँ अभी पकड़ो. नहीं घुमाते क्यों है? बस ऐसा. और बड़ा कर दो. हाँ. Now you can appreciate it better. You see the problem I am facing. It bounces on the wall, and then we don't know what happens. It's almost like a blind procedure, which is never good for any procedure. Okay. I am only in the wall here. Yogesh?
Yeah.
I think we should give up. I've tried enough, I think. Huh?
Yeah.
I'll probably
Safety
what I
comes
will do
first.
is I will try ERCP once again.
Plus minus spyglass maybe another option.
No,
Yeah,
then, the
should go first.
structure is very tight. So the spyglass is not going to help us there. See now, if we can puncture this thick wall here, almost see that looks pretty good. Okay, last. I said last 100 times.
That's a difficult case.
It just hits off the wall. Just doesn't enter the wall. See that?
Yeah.
Okay, I think we give up. I also have to go. I have to give a lecture at 7 o'clock to Italy. So thank you very much, Yogesh.
Thank you, sir.
Thank you, sir.
I hope you enjoyed. This was a failed case, but a lot of learning points in this.
Most important for endoscopists is, I think, when to stop. That's very important.
Yeah,
First,
it
do no
looks
harm.
that it's not possible. It's a very hard wall of the pancreatic duct. See this? This is like a cord, and I think she will probably benefit with surgery because there is a dilated duct. They can open this and do a surgical anastomosis.
Okay.
And then she doesn't have to go for all these things again and again. You see that? Looks like packed.
It's like a total stack
This is
of.
the only area where we can puncture and we are not able to puncture. But even if we puncture, we only decompress, probably reduce the pain, that's all.
But one thing I observed, you were not using at all Doppler, because we use a lot of Doppler. I see you are not at all worried where
See,
you
I
are
used
going.
initially, and once I know where the pancreatic duct is, then I don't need to use Doppler. Initially, you have to use what is happening in the area of the pancreatic tail, body tail, what are the big vessels, so that an initial impression you should get. Once that is there, then you don't have to use Doppler again and again.
Okay, but when you're giving a jab, it's totally moving, and there are big vessels.
No, that much I know. Every time I knew that my needle has not punctured. You will get a feel when it punctures somewhere deep, no? You know that it has gone deep. Here it was just pushing everything. It was not going through. It was just pushing the whole down. So that feeling is different from the feeling when it just goes in. So absolutely, that was not an issue. I knew that I was stuck and I was not going anywhere. It was right at the wall of the pancreatic duct. That's all.
Okay.
Okay.
Any questions for Dr. Dhir? Because I think he is going for another. Kadri?
No, very nice cases. Thank you for sharing cases.
Thank you very much. Thank you. Thank you. Thanks, Yogesh. Thanks all of you.
Very basic US FNACs, which is very important for us for day-to-day use. And of course, this is a complex procedure. And,
an easy case and a complex case, both.
And
so both
that's why biliary drainage or US guided drainage is not for everybody. It's not everybody's cup of tea. I think that's a very strong message. That
absolutely.
Even with experts, it is not so easy. So
you're very right. Absolutely right.
Endosonographer and gastroenterologist needs to know.
Yes. So I, as you know, Yogesh, I showed an antigrade yesterday, biliary antigrade to Turin, Italy. And today I plan to do a pancreatic duct. So the pancreatic duct was a tough one. So these things happen and it is okay. I think patient should be safe, most important. You should not create complications for the patient.
Sure.
Okay. So bye-bye.
Thank you, sir.
Okay, sir. Have a nice evening. Thank you. Thank you.
Thank you. Thank you. Thank you.
Can we switch to Hong Kong? Anthony, you're on.
Hello. Can you hear me?
Right. Yeah, we can hear you.
So
Anthony, I had a question. You guys are not using N95 or something. So how is it in your endoscopy? I see all the nurses using N95, but endoscopist is not using. I just wanted a.
Yeah. So actually, all our patients are tested for COVID before they are admitted to our hospital.
Okay.
As a standard, we suggest N95, but sometimes we can also allow the endoscopists to have some freedom.
Sure.
Yeah. So I think we're going to start with history, presentation of the history first. Okay, so
of today is 81-year-old gentleman He had a history of early gastric cancer with ESD done 2 years ago. Pathology showed intestinal adenocarcinoma with invasion to SM2, focally extending to deep margin. So at that time, he was a bit old, so he refused salvage gastrectomy. And the follow-up MBI OGD this year showed a new 1 centimeter lesion at the cardia, just adjacent to the previous ESD scar. And the biopsy showed high-grade dysplasia. This is the endoscopic picture. And so today we will show how to interpret this high-grade dysplasia and to perform EMR plus or minus ESD.
So I'm in with Dr. Yip right now, Yip Hon Chi. So he's our rising star in luminal endoscopy. So I'm gonna hand you the
okay, thank you, Anthony. Yeah, so I must apologize because this patient had, we started the case around 15 minutes ago, but we found out that the patient had a lot of food residue inside the stomach. So this actually makes interpretations of findings quite difficult. So we spent some time just now using ROVNet to remove all the food residue. So hopefully we can get a better view now. So most of the gastric content has been removed. So I withdraw my scope back to the OG junction, and actually you can already see this is not a Barrett's, but instead this is a scar from a previous ESD where part of it was healed by squamous mucosa. So on this white light endoscopy, you can see that the squamous mucosa actually extended down to the gastric side. It's because of the healing of the previous ESD. So now I'm using a conventional white light endoscopy. We're using the new Olympus X1, EVIS X1 system. So with this system, we have a few new modes that we can use. Commonly, when we're using the conventional white light, there's a new complementary mode we call the TXI. So now I'm changing to the TXI mode. So it's essentially a texture and color enhancement mode. So trying to enhance abnormal areas so that you may be able to detect these lesions more clearly. The exact utility of this TXI mode, I think, is still under investigation, but on just gross usage, you can see that it really gives you a better color and also texture enhancements. As you can see, this stomach is very atrophic, and you can see all the pale colored mucosa, even in the greater curvature, signifying significant atrophy and also probably with intestinal metaplasia. So if you look with the narrowband imaging, you can see very classical white opaque substances. So these are signs that signifies intestinal metaplasia. So we just freeze. So these are completely oblique substances where within these you cannot see any vasculature at all. So the SECN is covered by the white opaque substances. So these are due to lipid droplets being disposed in the subepithelial layers, so obscuring the vasculature. So we also can interpret these white opaque substances by looking at the regularities. So these are more gyrus-like or still regular appearing white opaque substance. So most likely it's a benign intestinal metaplasia. So now I'm going to change back to white light endoscopy and TXI. So because I'm using a magnifying endoscope, so I can actually zoom in various lesions for assessment. So I'm doing a retrospectoscope to look at the target lesion. So you can see the scar. So I'll try and distend the stomach a bit more. So there is the scar here in the middle where you can see the squamous extension. And now you can see a small elevated lesion over here. So can you see here in the middle of the screen, there's a small, slightly pale color lesion, actually very small in size, maybe at the maximum 1 cm in size. So, but there's obviously some spontaneous bleeding just now when we were trying to stop the bleeding. And this lesion is slightly irregular in the shape and also the color on top of it. So it's a bit suspicious. So whenever we see such lesion, of course, what I skipped is a global assessment of the stomach, but because of the time, I would not proceed to a complete assessment because it was done before. But whenever you see lesion, so what we want to do, with especially with a magnifying scope, is we try and move our scope towards the lesion from a normal area. So we magnify our scope. So now you can see medium magnification. So, and then we slowly move our scope towards target lesion. So I must apologize because of the bleeding. It's not shown very well. So sometimes you can add in water because the water actually gives you even better magnification. And also it reduces the reflection of light in the air. So I magnify a bit more. So from normal to abnormal, it's a bit difficult to see because of the clots on top. So, but here you can see some abnormal vessels in the center, but it's covered by clots. Okay, so you can see on the left side is 7 o'clock is the normal mucosa, and on the center of the lesion, it's slightly irregular, but the vasculature is quite difficult to see because of the bleeding occurred just now during removal of food residue. So, but anyway, the technique is like this. So in a retroflex position, you anchor your scope with the black hood towards this normal mucosa and then slowly move towards the abnormal area and then freeze. So you can vaguely see the center of the lesion with some irregular vessels. I don't know if you can see well because there are some clots covering it. But there is an obvious demarcation between the normal and abnormal mucosa. So given this lesion very small in size, but it's slightly adjacent to the previous ESD scar. So I think we would try and do a ESD for this lesion just to ensure the adequate margin and also better tackle if there is any abnormal submucosal fibrosis. So now I'm going to proceed to marking of this lesion. So there are a few ways for marking. You can just use narrowband imaging, just like what we did. Some Japanese prefer to use the additional chromoendoscopy in order to see the margin clearly. In my opinion, I think if you are able to define the lesion well with narrowband imaging, probably you don't really need the addition of chromoendoscopy. But of course, chromoendoscopy has its own benefit because it also shows lesions quite well. So today I'm going to do the marking with a flush knife.
So Chi, do you think this lesion is a bit raised?
Yes,
Where is some submucosal invasion?
Yeah, there's some slight elevation, but so important thing is to distend the stomach well enough to see how elevated, and also if there is any what we call a non-extension sign. So non-extension sign essentially means that the adjacent muscular layer cannot be, so there is a ridge on the adjacent mucosa, but I think although it's elevated, but still it's flat on the side.
Yeah.
So there is no non-extension sign to suggest a deep invasion. But of course, all these signs are at most about 70 to 80% accurate. Okay.
Are you using some new scope or something? This is I can see RDI and TXI.
The system is new, but the scope is the regular 290 zoom scope. So we are not using the 1500 series at this moment as for the scope. But there's we are waiting for the new scope to come. So at the moment we're using the conventional zoom endoscopy.
So with the so you showed the THI filter. Yeah. I think later on, if we are unlucky to see some bleeding, you can show us how you use the RDI.
Yes.
So RDI is basically a color mode where the blood turns into yellow color. So with that system, they claim you can see the bleeding site easier and also less stressful for the endoscopist, right?
Yes, yes. But yeah, we're still yet to see the exact benefit of it, but I think it's exciting with all these new amber lights. So the rationale behind the new RDI is the addition of amber lights. So the amber light actually helps to make everything yellow. So
you can show us now the RDI just quickly.
So sorry, let me try. Yeah. So this is
So
the
RDI looks like this. So it's a yellow color.
So if you see blood, it's
Jaundice
yellow.
patient.
So not scary.
Yeah, but right now it's not useful. So I think later on, hopefully we won't see a lot of bleeding, just enough to show the device.
Yep.
But this stomach is
What
quite.
about EMR in this lesion? If you can elevate it, then will EMR be enough,
it's a very good
or you have to
question.
go for
So
ESD?
there are a few reasons I chose ESD. So first of all is because of the lesion's nature. This is a lesion that arises from near a previous scar. So I'm not sure if the scar may make EMR difficult. And secondly, there are actually some studies to show that for lesions in the stomach, it's actually quite difficult to get a negative margin, especially if there is a cancerous, suspicious of cancer. I think it's because sometimes, although macroscopically you can see the lesion quite well, but during the assessment pathologically, we do see that sometimes these lesion has a submucosal or subepithelial spread to some nearby structure, to the adjacent normal, underneath the adjacent normal epithelium. So that may make a EMR more tricky because the margin that you get may not be as wide as you get from an ESD. So that's all, but I must say this is only my personal opinion. So, but if you look at data from Japan, actually you can see that the ESD ratio is much higher than what they see in the EMR. So I must say ESD has some advantage, and also if you are good at doing it, then maybe it's not as difficult as you imagine. So, yeah. So I think I've completed the marking around the lesion. It's quite nicely seen now. So inflate a bit more to see the exact marking better. So perhaps this is a good enough marking. Probably just make sure you can see the surrounding structures, each of the mark better. So I will now change the scope. Well, I'm not changing the scope, but I'm changing the cap, because if you do ESD, we would not use this soft black hood, but we will use a straight transparent but longer hood to get the stabilization of the scope for the retraction.
Gee, how about a hybrid EMR?
Yeah, that's also a good idea. I think it's quite popular among Koreans to use the hybrid procedure. Some of the data that we saw is quite promising, but personally, I don't have very good experience in hybrid procedure. But I think it's probably less cost less time. But other than that, I don't think there is much difference in terms of the outcome.
Yeah.
Yeah.
Is it a
What about full
tapered
thickness
hood that you're using?
CRD or something?
Can you say that again?
Is it a tapered hood that you're using now?
What cap are you using?
This is just an Olympus straight cap, transparent.
Just a straight, short, hard cap, right?
Yeah.
And Yogesh, what were you saying?
I was asking, what about FTRD? You know, you can just through and through, you can cut it and.
Yeah, but it seems an overkill. If this is just a mucosal lesion, we don't really need a full thickness.
Oh, full thickness. Oh, yeah.
More expensive.
Yeah, and it's quite expensive. So maybe if there is a suspicion, some mucosal invasion, then maybe. But again, we need to bear in mind that for gastric lesion invading to submucosa, there's always a risk of lymph node met. So doing an ESD would not be enough. So it's a trade-off. But maybe for very fibrotic lesion, but still clinically suspicious to be mucosal lesion, then yeah, maybe.
What solution you are using?
So I'm using a combination of normal saline, indigo carmine, and also with epinephrine. So my own practice is that I don't add much dye in my ESD. Okay.
So you just use white,
just
clear, transparent, right? Okay. So I think some experienced endoscopists, they prefer just
You don't use a colloid or gel fusion or something like that, some special.
No, there is some sodium hyaluronic. So Mucoab or the Japanese.
So hyaluronic acid mixed with saline, but any adrenaline? No adrenaline? Some adrenaline, and then but no indigo carmine.
Any particular reason why you're not using indigo carmine or methylene blue?
I think it doesn't really matter. So if you, I learned from my teacher from Japan. So my teacher didn't use any color, so that's why I follow him. But I think if you go to Tokyo, a lot of endoscopists in Tokyo, they prefer to use color. But nowadays, I think for most experienced endoscopists, even if they will use a very diluted dye, because too concentrated dye, you would see that the vessels are almost obscured by the dye. So your visualization is difficult, especially if you see vessels. So maybe a very light dye can also help enough for the assessment. So now I've almost completed the circumferential injection. So just here that I need to inject.
So what would be your approach? You'll go from proximal or you'll go all around, or?
In this lesion, in the lesser curvature side, I think I would just start circumferential incision, but from the retroflex view from the anal side.
And what would be the choice of your knife? What knife do you prefer?
So I'm just using the previous knife that I used for marking. It's the flush knife. So I think generally the knife, the type of, you only need to bear in mind the type of knives. So for myself, I prefer to use a knife, either a dual knife or a flush knife if I need a needle type knife. But for a difficult gastric lesion, then I think the addition of IT2 knife is extremely useful, because there are locations where the needle type knife is very difficult to reach. So in those situations, then I would prefer to change to a IT knife to get the easier so to get the easier approach. So there are different principles when you're using a needle type knife versus when you're using a IT2. So dual knife or flush knife, what you need is just injecting, just starting from near side to far side. So what I mean is from the near of the endoscope to the further of the endoscope. So if you're practicing, you can just try and touch on the mucosa and then move your scope along the intended incision line. Then you will see whether you can get a smooth a rotation like a movement. So the first cut, you push your knife onto the mucosa, slightly push so that you get into the submucosa, and then you drag a bit to the lateral. So you can now see the mucosal incision and exposing the underlying submucosa. So now you can see the submucosal tissue. So I just follow my incision line, intended incision line. So it's important that this step is not very deep. As you can see, if you go too deep, you cut this vessel, then you will have bleeding. So try and get just shallow incision so that you will not result in a significant bleeding during the mucosal incision. Then those vessels can be coagulated with the coagulation mode. So just follow the incision line.
You can tell Chi is doing it very controlled, very everything is very slowly, so nothing to rush.
Yep. So I think yeah, there's always time. So instead of rushing, I think it's more important to ensure that the bleeding is well controlled, because once it bleeds, then it will become more difficult to visualize the correct plane. So this is my own practice. So just go slow.
Are you planning to completely cut the mucosa?
Yes, I will.
Okay.
I will. So, but I would try and go deeper first and see better. So there's a vessel here. I will control it with just a simple coagulation. So some more bleeding here. Control it, and then flush a bit more. So there's a small submucosal vessel. So generally, you can try and cut them. So if you can't see well, flush with water, and then identify the right plane again, and then coag. So now you can see better. So once you see the transparent layer, then this is the right submucosal layer. But it's better if you can cut slightly deeper so that you are able to see the muscle layer. So the ideal plane of dissection is actually in the deep submucosal layer, because that gives you the best layer for dissection with less bleeding. And also your specimen will be more under control, because your specimen have a deep submucosal layer that you can actually see the specimen and the pathology contains a deep submucosal layer for better assessment. So I can actually complete the mucosal incision now with the antegrade view also. So I just trace it back here. So the opening was made to here. So so I can perhaps start the mucosal incision this side, but I think that the injection is not enough here, or there may be some scarring over this region. So I would just cut here slightly.
What about a hybrid ESD in this case? Because it's a small lesion, you can cut around and just put a snail and take it off.
It's applicable to this case is possible. I agree with you. So for such small lesion, then a hybrid procedure is definitely possible, so that you can maybe save a bit more time. So the stomach is not distended well enough. So that's why the mucosal incision is not effective. So we preferably, we want to distend the stomach a bit more. So now I'm getting in. So tracing back. So perhaps I will inject a bit more. I feel that the injection is not good enough. Injector. So the flush knife actually has a flushing function, so you can flush. So to achieve a better elevation. So here as well. Okay, so there's some bleeding here. I'll stop it now. Okay, it stopped. Then another blood vessel here. I'll slowly coagulate. So it stops. Much better. So just touch onto the vessel. Sometimes you need not change to the coag grasper if the vessel is still small in size. So I would continue the mucosal incision. Okay. So I'll go back to the center, and hopefully I can get to the deeper submucosal plane. So you can already see the underlying muscularis propria layer, but still there's a layer of submucosal tissue, so we can dissect a bit more to expose the muscle. So I think some European authors actually like to use the underwater technique for ESD as well. But in this situation, I think it's not needed because this is in the anti-gravity position. So water will not stay. So probably not useful in this case. There's quite a lot of fatty tissue in the submucosa. You can see here.
So far, no fibrosis from the previous.
I think no, but maybe in the proximal, I'm not sure, because the scar is at the proximal. So I'll clean the knife because it seems a bit dirty, and I'll add some injection so that I can get a better submucosal plane injection. So perhaps I can add a bit more for this this side, and that's in the two lateral side as well.
What are the cautery settings? One of the attendees is asking. Can you show your cautery and show the cautery settings?
So I'm using a Irby 300D system, and the cutting is endocut I, effect 2, duration 3, interval 2, and I'm using forced coagulation, effect 3, maximum volt 40. So when you inject, you try and avoid the vessel. You can see a large vessel here. Okay, so I hope to inject a bit more on the proximal side. I think this is still not very good enough. Hold住支鏡。I think this is probably a bit scar, but not too bad. Okay.
Does the non-elevation of a region or a part of a lesion is an indication to give up, or you would continue?
I would review the indication. So I don't think the non-elevation is an absolute contraindication. So we always go back and see the original lesion description. As you may aware of the Japanese guidelines, so they have a preset specific criteria for a potential indication for ESD. So sometimes even an ulcerated lesion can have significant fibrosis, but if it's still fulfilling the original indication criteria, it may not be necessary to abort the procedure at that juncture.
I mean, so far it's cutting reasonably well, but when do you decide that you're going to use traction? At one stage, we'll say, this is not well, I need to use traction.
So it will depend on of course, the difficulty of the procedure and whether or not you can achieve a good retraction by the conventional method. Correct. If you cannot, then perhaps it's time to consider changing the tactics. So it's always a review of the progress of the procedure and decide what to do next. So I think generally for lesion in the lesser curvature, because it's in the gravity side, so may not be as necessary for a traction procedure because of the absence of the gravity is actually helping you to do all the work. So I'm sorry the patient is moving a bit, so I'll need to cut this side.
So you don't do this procedure under general anesthesia?
This is a rather old patient, so we did not want to risk him under general anesthesia, so that's why I chose to perform it under MAC, so monitored anesthetic injection. So I think we have done maybe half of the lesion now. So it's time to complete the mucosal incision, otherwise it's difficult.
This is a relatively, looks like a smaller lesion, but can you comment a little bit for us, like a pocket technique? Like when do you decide that I'm going to make a pocket, or just going to, or whether you're just going to use this circumferential incision and take off the central part later on?
To be honest, for gastric lesion, I think there is not a common indication for doing the pocket creation, because the lesions are, even if the lesions are large, there are always ways to mitigate through the submucosal layer and also achieve a retraction. For example, the use of clip line traction. But I think a pocket creation is particularly useful for colonic lesion, especially if it's located in the, for example, transverse colon, and if there is a difficulty in achieving a stable scope position, then those are situations when you should consider a pocket creation injection. So I feel that this side, the injection is still a little bit suboptimal, so I'll inject a bit more. Okay, so you can see the elevation better now. So down.
Yep.
Down. Down. Okay. Oh, okay. Stop. Okay. Okay, we change back to the knife. So I think we need to tackle this vessel. Sometimes if you are patient enough, there is if you're using the needle type knife, there's a mode that you can use. It's called 110 mode, proposed by Professor Toyonaga, where you can actually using a low voltage while maintaining the needle type knife for the hemostasis. So I'll show you what it does. So it's force coac 110. They call it 110. So effect 1, max watt 10. So it gives you a slow cooking results. So okay. So for example, we're dealing with this vessel here. So we gently touch onto the lesion on one side. Don't give too much pressure, just gently. So it will give a slow cook until the vessel is whitened. So it's not completely whitened yet, so you need to add a bit more. So this is a slow cook, so it will not cut the vessel. And then until you really get to a point where you feel that the vessel is completely whitened out, then you can change it back to the original coagulation mode for the cutting of the vessel. So once you can see the vessel is almost white now, so we change back to the mode and then we cut.
Do you think we can deal with most of the vessels like this, or how often do you need to change to coag grasper? Or are you
for gastric, it's a bit tricky because gastric sometimes, especially in the lesser curvature, there are really huge vessels. So I would say for gastric lesion, especially in the lesser curvature, you need to be cautious. But just now that vessel is not very big, so I think it's still reasonably safe for this mode. So there's still a bit of bleeding, but I think most of the vessel has been coagulated. So I proceed to cutting onto the side. So somehow the submucosa is a bit fatty in this patient over this region, and there are
yeah, it's quite fatty. Usually you see this more in the colon.
Maybe in the right colon it's more commonly seen, but somehow it's quite fatty.
And also his stomach mucosa is quite diseased, huh?
Yeah, it's very atrophic and extensive intestinal metaplasia.
So that's why he's having all these recurrence.
Yes.
What is the consensus in your practice for taking biopsies for these lesions? What do you advise our viewers? Do you take biopsies, or if you find anything like this, you refer it to the specialized centers?
I think it's okay to get a biopsy. So generally, biopsy would not affect the gastric ESD procedure. So as long as you are not taking jumbo biopsies and a 6 or 7 specimen, then I think it's okay. It's acceptable. But of course, it's best if you just get 1 or 2 biopsy at the most suspicious region. Then it's enough information for the procedure planning. Then I think it's enough.
I mean, of course, there's always a risk of causing some fibrosis on getting some biopsy. But I think for stomach in general, even if there's some fibrosis, it's not difficult to handle.
Yep.
So I think it's okay for the stomach to. Let's change the RDI.
Yeah, we can change the RDI. So there's a bleeding here.
Okay, so this is RDI mode. So because now it feels very different, right? So
this looks
because you don't see the blood, you don't get so stressed, and you seem to be able to see the where it's coming from better. Okay.
Okay, it stops. Still some. Okay, so I can change back. So it's still a bit.
So for the esophagus, fibrosis maybe more affecting, but as long as you don't take so much, I think it's okay. But in the colon, I think not the biopsy that affects most is the tattooing, right?
Yeah, tattoo will cause quite significant problems. So if you tattoo far away from the lesion as much as possible, maybe 1 or 2 folds away. So just to let the referring endoscopist know where the lesion is around, but not really exactly at the lesion.
Can you comment on how do you do surveillance of these type of high-risk patient who had a lesion in the past and extensive intestinal metaplasia? You obviously in the Asian country, I mean, what's the protocol you follow at your center? Because we have very limited experience with these, so this is something we always struggle with. What's the surveillance policy in these type of patients? And when you do the gastroscopy, how do you do that?
I think for patients with a known history of cancer or history of a dysplastic lesion, we at least generally will offer them yearly annual surveillance. So because there are still quite commonly seen metachronous lesions. So I would still suggest to get regular surveillance for these cases. So maybe yearly at least.
And just a simple white light examination, like taking your time, or any other modality?
I think at the moment, so there are no study to show, or maybe there was some study, but at least at the moment, the standard is still the white light endoscopy. But the use of image-enhanced endoscopy, for example, narrowband imaging, still it hasn't shown a definite benefit. There was a study on using BLI from the Fujifilm. Seems that there is a slight increase in the in the yield of lesion that has been identified. But I think it's still too early to conclude that routine use of BLI or NBI is useful as screening. But of course, if you see target lesion, then I would definitely advise to add NBI to better assess the lesion. So here I can see a slightly bigger vessel. So I think it's safer to coagulate them first with the grasper. So let's change to a coag grasper.
And,
So
okay.
yeah.
Can we also change the RDI
There
to
appears
see
to be
the
some fibrosis there as well.
Yeah, I think there is. But it's quite common for lesion in the lesser curvature to have fibrosis. So it may be related to the cancer itself, but it's also the nature of the stomach. In the lesser curvature, there are some natural fibrosis, especially around the region where there are sling fibers or the oblique muscle fibers. So it's quite natural to see these.
Going back to the screening, actually, for us, all these patients in the first year, they would have a 3 to 4 monthly EGD, followed by a yearly surveillance. I think for you guys, maybe you will see more Barrett's associated adrenodysplasia. We also follow the same sort of surveillance regime after resection of Barrett's. I think in terms of image enhanced for the stomach, it's not definite, but I definitely use it. I think she also does it. We do have a dedicated session, narrowband imaging session, where we try not to book so many cases and have ample time to survey these lesions. In the esophagus, in Hong Kong, we see more squamous.
Yeah,
and for me, I think squamous definitely NBI is more useful. How about in UAE? Do you see more squamous or adenocarcinomas?
None of these, to be honest.
Neither.
No, very upper GI cancers are not very common. Yeah, for some reason, even Barrett's.
Actually, there's a bias here because we have a lot of young population, of course, except for like Badri and some of the institutes who see some older, but most of our population is quite young. They are healthy workers, so the incidence of these lesions are quite less. The rectum, colon is much more common, and we are seeing a lot of pancreas, the neuroendocrine, and these lesions coming up, or they are being detected more. But the upper and gastric lesions are quite rare.
Even Barrett's, I mean, despite a very high prevalence of obesity and smoking, for some reason we don't see Barrett's. Actually, very rare.
Often. Isn't it tempting to put a snare and take it off?
Yeah, it is, but I think the mucosal incision is not deep enough now. So even if you put in a snare, you might slip. So I would prefer to add, to maybe at least if I want to snare, even if I want to snare it, I would get a bit deeper. So here you can see the submucosal fat, and then just beneath is the muscle. So I think it's better that we get the better margin. So since this patient is not a surgical candidate, so if we couldn't get a nice margin and get a recurrence again, then it may be very difficult to manage later.
So just for lesions in this part of the stomach, it's always like you go retrograde to like in retroflexion, or is there any time you will
I think both is okay. So for example, if you sometimes if you need, you can actually change your position to the straight scope. But sometimes I feel that a retroflex position, the scope is actually more stable than the straight scope position. So this is sometimes my own preference.
What about J knife? Do you don't prefer that because you can inject as it?
Sorry, what knife?
Which runs on that?
What?
The
Sorry, I
dual
can't
J.
hear.
I mean,
Dual J. Yeah, I use it too.
the dual J knife. Do you? Will it be beneficial because you can inject as well as you can cut with it?
Actually,
So
the flush
what's
knife
your
also
take on
had.
that?
Actually, the flush knife also had the same function. So it can also inject with the flush knife. So I'll show you. If you add a pump, then actually the flush knife can work magic as well. But sometimes if you really want to get very good elevation, it's no harm to change the needle and get a bit injection as well. So I would supplement with injection through the water jet knife. So the flush knife is actually has a very, very good flushing function as well. So I can ask the nurse to demonstrate. So you can see. Okay, can you see the flushing? Maybe difficult.
Yeah, yeah, sure.
So as you can see in this area, the scope is more unstable. So that's why I did it the antegrade view incision first, because retroflex incision first, because the scope is not as stable in this position. The patient is moving a bit now, so I'm sorry. Okay, 打針。打。OK， 好停。打針準備打你嗰度，等陣啊，打。OK 停。
Any role for artificial intelligence in identifying areas of intestinal metaplasia?
Sorry, can you repeat your question?
Any role of artificial intelligence in directing biopsies for surveillance or
I think if you have good endoscopic diagnostic skill, random biopsy of intestinal metaplasia, it's probably of very low yield because most of the time you can diagnose the cancerous area quite accurately with the use of narrowband imaging or any technique of image enhanced endoscopy. So to answer, I would not take random biopsy for the IM as a routine.
In your practice, how often do you find during surveillance the intestinal metaplasia getting converted to high-grade dysplasia and malignancy?
It's actually not very common. So it also depends on the degree of intestinal metaplasia. So you need to see if the IM is very extensively affected in the stomach. So if it is, then perhaps the risk is higher. But if it's not, then the risk is not very high.
I think in clinical practice, we have this very often, you have intestinal metaplasia and patient is really very worried and they keep on
I totally understand.
different
I think we
gastroenterologists
also
because they go to
sometimes
the Google, they go to the internet and then they read about it and they keep on getting worried about it. So
yeah, but I think even if you look into the European guideline, the MAPS2 guideline, so they only suggest the use of intestinal metaplasia surveillance in those cases with extensive IM. So I'm not sure the yield of doing these kind of surveillance or even biopsies for lesions for focal IM. So I think the difference is in Asia and also in the other, for example, European countries or maybe in Arab as well, the incidence of gastric cancer is different. So there is a difficulty in generalizing every practice from different countries into the countries with different prevalence of gastric cancer. So ultimately, it needs to be decided on the based on the local prevalence and the yield of doing a routine screening or surveillance of intestinal metaplasia. So for instance, in Japan and Korea, they do surveillance almost regardless of the IM status because they're by default the population risk is too high. So the situation in Hong Kong is more tricky because our cancer risk is not as high as in Japan. So generally, we would not recommend routine screening for those cases with only intestinal metaplasia, but we would do perhaps, as you mentioned, high-risk screening. There's a rather large vessel here. Okay, I'll change to coax grasper.
use a TXI mode.
So it's here. So with the RDI, the color is less scary, but still you need to
It really
focus.
takes the load off your.
Yeah. You feel more relaxed since the color is no longer red. But still try and press onto the bleeding site with your scope and also the cap. So the bleeding will slow down because of the pressure effect. Then just applying a bit of water jet, then you can see the bleeding site more clearly. Just like this. So sometimes suctioning may not be as effective.
Nice demonstration, very nice. So this bleeding can really sledge you and sometimes it can be really difficult to progress.
Yeah. So we grabs it, we check,
No bleeding?
That's
It
correct.
means you're grafting it well. Okay. Then we coact. Ginger sauce. Okay. All right. So we check again. Mostly stopped. So maybe still here, there's a vessel. All right. So we graft this. Then cut.
This looks like a big vessel.
Okay. All right.
So it's also a very practical tip how nicely he demonstrated that you have to the vessel and you have to retract, because if you put coagulation and you're close to the submucosa and there's a muscle layer, especially stomach, not so much, a colon or rectum, it can really be a problem because it can really cause a perforation or small leak if you're not careful.
We're almost done.
So it's very retracted towards you.
Yeah, so you need to pull back a bit so that you can get some space from the muscle layer, especially if you're doing colon. Gastric, the safety margin is higher, so there's maybe less risk. So there's some scarring over this region, but I think it should be okay. Okay, so we'll clear up the fluid because we injected quite a lot just now. Okay, we continue.
What's the protocol you follow for anticoagulation? Is Plavix okay now, or you still stop the clopidogrel? Or
For this, we're still a bit conventional, so we probably would prefer Plavix to stop prior to the procedure. But aspirin is definitely okay. I understand that in Japan, they have now changed the national guideline. Even if a patient had a prior warfarin, they still allow the procedure to be done. So it's slightly different in terms of their practice. I think here is where the fibrosis is.
Yeah.
So you can see the muscle layer slightly elevating up. But we are towards the end, so I'm not very worried. And as long as we can get this region out, then probably it's okay. So it's a lot of fluid, so it's suction a bit more. So here.
any special tricks for the last 20 or 10 minutes when it gets difficult to resect, or do you just keep doing what you have been doing before? Do you do any other?
I think if
that's always the difficult part, isn't it? Yes.
Yeah, I think the important thing is always planning. So sometimes, for example, if you're doing the procedure in the middle, it's usually more advisable to start the procedure by doing the difficult part first. The reason is that the difficult part would get more difficult towards the end. So, well, in that sense, I'm not following this guidance today, but I think this is still okay because I expect the fibrosis region to be rather not very extensive, so I think it's still okay. But if you are anticipating a very extensive fibrosis, then perhaps it's better to tackle them early on, or at least try and get the right plane early on, so that you can tackle the fibrosis region for sure. So this is where there's some fatty tissue, so probably still submucosal. In this position, the scope is not very stable. Okay. Seems to be a lot of fats in the submucosa for this patient, which is not common for gastric lesion, I must say, in general.
I have asked this question in earlier sessions. What's your hospital protocol? Do you admit them overnight, or is it a day procedure?
Yeah, we do. We are for this. We are rather conservative, so we do admit them. Well, we can admit them same day, but they will be staying with us for at least 2 or 3 days afterwards, until we're absolutely clear that there's no worrying complication, etc., before we let the patient go home.
I think in Japan they are much more conservative because
yeah,
a lot of
I think maybe also issue of traveling. So sometimes patients need to travel quite a bit to get to the hospital. So maybe that's also some of their concern. Here is definitely fibrosis. So the principle of encountering fibrosis is just to follow the line. So you imagine the submucosal plane and follow the plane.
In the stomach, as in Barrett's, can you try banding? In Barrett's, I've seen people try banding and then do the mucosectomy. Actually, so
you mean pen-assisted EMR? Yeah, I think the band-assisted EMR, the specimen that you get is much smaller than what you can get from cap EMR. So if you're doing a EMR type of procedure for these lesions, I would prefer to use the cap EMR technique rather than the band-assisted technique. So what you mentioned is you use the band, like the bending that you use for varices, and then apply a snare beneath the band. Is that right?
Yeah.
Yeah, I think for this kind of procedure, it's quite useful for Barrett's, I think. So, because I've seen endoscopists using that as the technique for multifocal dysplasia in the Barrett's, and that's quite useful, I would say. So, in those situations, I would use the band-assisted procedure. So I think we are only here. We're only here left behind. So we'll cut here as the fibrosis area. So here.
The last few bites.
Yep. So occasionally, I think in some difficult situation, of course, changing to a IT knife would definitely help, and maybe may reduce the risk of complication as well. But because the IT knife has a safety margin, but unfortunately, we do not have that in stock today for some reason. So we have to stick with this needle knife for the rest of the procedure. But I think it's okay because we're almost done.
Few last cuts to the glory.
But sometimes, as your colleague has mentioned, the last cut could be the most tricky one.
That's it.
So maybe here.
Almost there.
I guess it's easy at the end if the gravity helps. Otherwise, it's more difficult.
Yeah, gravity is our friend.
Yep. So we review here. We are only here left here. So it's really the final part. So, but this is a fibrotic area, so I have to cut with bravery. So hoping that there is no perforation. But from my teacher, what my teacher told me is fibrotic area, the key is to cut slightly deeper, because usually the margin is, the scar is slightly deeper. So it's okay to cut slightly deeper in such situation, and I'm done.
Yeah.
So
all right. Very nice. Thank you.
So we'll clean the area, and then we'll do hemostasis, and then we'll retrieve the lesion as well, and put it onto the a plastic, fix it onto a board so that we make sure that the detailed pathological assessment is possible. But before we do that, it's important we check the defect to see if there is any visible vessel. So coagulating visible vessel is crucial step in gastric ESD to avoid delay hemorrhage. So study has found that prophylactic coagulation reduce post-procedural delay hemorrhage. So just try and find those pulsatile vessels and the visible vessels and coagulate them first. So for instance, in the side of the edge is most important sign, because these are areas where the vessels are partially cut. In the center of this lesion, most likely you have already coagulated the lesion, the vessel quite extensively. So the delayed hemorrhage, according to experience, is most likely from the edge. So try and look for the vessels in the edge, and then
All
coagulation.
right. So Yogesh, do you guys have any questions? I think it's past your closing time, right?
What about Purastat? Do you use it for the defect to put something on it? Is it available with you?
We have used that before, so I think it's reasonably useful. But I think there is no strong evidence to support the use of it. But I think adding it, well, at least the cases that I used, I have not encountered any bleeding. So I like it, but it's quite expensive. So I'm not using it routinely.
When do you decide the close? Like, I mean, in the stomach, do you close the gap, like, or do you clip the gap, or you like colon, or you just? Or when do you decide that I'm going to close it?
Generally, I don't think it's necessary. And for gastric lesion, the defects are usually huge. So it's not easy to close the defect. So for example, like in this case, the defect is quite large. I would say it's not impossible. There has been a report from Japan trying to use suturing and also with clip and loop techniques to try and close these lesions. But I don't think there is evidence to suggest that closing the defect will reduce the delay hemorrhage at this moment. So I would not routinely do it. So this is the defect. I think there's the muscle is still intact. There's some scarring over this region, but otherwise everything's good. So I would end the procedure now. And yeah, so thank you so much.
So thank you very much, Yogesh. Thank you very much from UAE. Yes.
You said you had another case, a USBD or something. Is it? Will it take time for it to be coming online, or?
Yeah, it will take some time, and then probably that case is not easy because the patient already had US GJ done, and then this time had biliary obstruction. Maybe it will take another hour or more. So maybe we will need to close after this case.
Okay.
Just one question, like after such a mucosal defect is created, any role for PPI post this thing for like it's like an artificial ulcer there? So,
yes, I think there is definite evidence that using proton pump inhibitor is better than H2 blocker. There are also some evidence to suggest that using the potassium channel blocker can also achieve similar effects. So it's another alternative that you can choose. So yeah, so basically that's it.
And how long should we continue the PPI?
For about 1 month to 2 months. So 6 to 8 weeks is generally enough.
Okay. Thank you.
Any other
All right,
questions
so
for the?
Any more questions?
No, I think panelists are also tired, I believe.
Everyone's tired.
Yeah. So very nice cases, very nice demonstration. It was really a difficult case with a lot of fibrosis. Excellent dissection.
Yeah, so I think the lesion, if you can see the screen, so it's completely resected with a good margin. So we'll wait for the histology.
Sure.
Yeah. Okay.
Okay.
All right. Thank you very much.
Thank you.
Thanks, Anthony. Thanks for your time. Thanks for demonstrating a nice cholangioscopy, and thanks for this case. Thank you.
Thank you.
Thank you. So thanks for inviting us. Hopefully we'll meet sometime soon in person.
Sure. Once the COVID epidemic recedes, we'll meet. We'll meet surely.
Everybody, please take care.
Yeah, sure.
Okay. Bye-bye.
Okay. Bye. So at the closing, I think I'd like to give a vote of thanks to everyone. So today it gives me an immense sense of satisfaction to bring in on this platform loads of information, knowledge, which was given to us to absorb. This has been possible because of joint effort from everybody. It was a very knowledgeable journey throughout this conference. Kindly accept my heartfelt thanks to all the peoples who are involved in this congregation. My sincere gratitude to all the speakers who have had valuable time. We really had a good galaxy of stars from all over the world who really took time from their busy schedule. Most of them are extremely busy, but they took time and they actually contributed to our learning. A honest thankfulness to the moderators, the national faculty who are on a weekend, they took out time and moderated the session beautifully to make this a successful event. And of course, the delegates are the most important part of any meeting. They were very patient and they stayed till the end to continue learning. I have no words to express my gratitude towards AEG for the platform they offered, especially to Flora for her excellent and immaculate work at the back end, and Jason for their constant and seamless support to online as well as offline. Back home, I would like to thank my endoscopy family, my colleagues, my staff who worked tirelessly with me to put together everything. And last but not at the least, I would like to thank our marketing team headed by Mr. Rohan, which worked very, very hard to bring it to this level. Thanks everyone. Hopefully we'll be able to meet next year physically, not virtually, and we could have a nice sumptuous lunch in between our meeting, which was really missing from this part. And the most important thing is to connect, to meet, to interact with everybody, which was really, really missing. But of course, we are going through the tough phase. We hope this vaccine brings in changes and we can meet everybody soon. Thank you very much. And thanks for joining.
Thank you, Yogesh.